The Royal Commission is now in session.
We begin by paying our respects to the traditional custodians of the lands on which we meet, the Gadigal people of the Eora Nation, and we pay our respects to their elders past, present and emerging. Mr. Gray.
Thank you, Commissioner. In this hearing, I appear with Paul Walster and Eliza Bergen. The hearing will be conducted by remote links from the hearing room here in Sydney with witnesses in various places. We too of Council wish to acknowledge the traditional custodians of the land on which we meet, the Gadigal people of the Eora Nation, as well as the traditional custodians of the lands from which our witnesses appear over the next 7 hearing days, and to pay our respects to their elders past, present and emerging. The topics for the hearing are the funding of aged care, including reporting and prudential requirements, and potential financing options. These topics are, of course, highly relevant to your terms of reference, Commissioners, and in particular to strengthening the system of aged care services to ensure they're of high quality and safe, and how best to deliver aged care in a sustainable way, including through innovative models of care, increased use of technology and investment in the aged care workforce and capital infrastructure. The topic is large and technical. Funding is vitally important, not only because it's critical to capability to provide aged care, but also because the way it is administered can have a profound effect on quality. The inquiry into it is far-ranging. This hearing is merely one part of that inquiry. In these opening remarks, I will refer to the key concepts and issues, but will not attempt to be comprehensive. The hearing can be seen as part of a project aimed at a number of important objectives. First, funding aged care to a level that's well calibrated to meet needs on both the level of the individual who's receiving care and in an aggregated sense, system-wide. Next, ensuring via incentives and administrative mechanisms that there is accountability for expenditure of that funding on the purposes for which it is provided. Next, protecting against financial risks that might endanger continuity of services, harm the interests and welfare of care recipients, or in some cases potentially place Commonwealth guaranteed loans at risk. Next, attaining an equitable balance between public financing and contributions from the individuals receiving the services without impeding access to those services. Next, identifying the best options for stable, long-term financing for the system. Finally, identifying the principles that should inform the transition to new arrangements, including a proactive and accountable role for government in steering the transition. All these objectives are linked. Take the objective of calibrating funding to need and the objective of ensuring accountability. In order to improve the quality and availability of aged care, it's necessary to improve the way it is funded. This is likely to involve more funding appropriately targeted, but it's certainly not just about providing more money. It's also about creating a framework of incentives, rules, and oversight to ensure that the money is spent appropriately on the delivery of high quality care. This will require transparency and accountability about the expenditure of money originating from Commonwealth subsidies and compulsory contributions from individuals. There are some surprising features of the current arrangements in that regard, Commissioners. For example, home care providers are not required to report to the government what kinds of goods and services are provided with the home care package subsidies that the Commonwealth supplies, which amount to about $2.5 billion a year based on 2018-19 data. To try to gain an understanding of what those services are, the Department of Health has recently conducted a survey of home care providers and the results have been disturbing. The survey revealed that in 2018-19 there were negligible amounts spent on nursing and allied health care of only about 15 minutes per fortnight, even for people on the higher levels of home care package. Residential care providers receive about $11.7 billion a year in total Commonwealth care subsidies and about $12.4 billion overall in overall care-related revenue, that is, including contributions from residents. They also receive fees for additional services and deposits for accommodation or charges that are supposed to be equivalent. They also receive fees for additional services. However, according to experts engaged by the Royal Commission, BDO, residential care providers' annual reporting requirements do not adequately reveal how that money is used or what profit or loss is made in providing residential care services because of complications in relation to corporate structures. The prudential reporting regime does not require providers to submit sufficient information about related party transactions on matters such as loans and interest, management fees and rent. Now, it's not to criticise those arrangements, but it's just that the reporting is inadequate to reveal what they are. Further, there's no specific requirement on residential aged care providers to spend any particular portion of that money on care. And as your council assisting have pointed out in our February workforce submissions, there's no direct requirement on them to maintain particular levels of staffing or to provide particular time of contact by staff with care recipients. The only requirement in that regard being a requirement to maintain a level described in vague terms as being adequate and appropriately skilled. Commissioners, I'll ask the operator to display the index for the general tender bundle for the hearing. I tendered a general tender bundle for the hearing, documents in which will be available generally to the public on the Royal Commission website via the Public Hearings Document Library page and the Exhibits filter.
Yes, thank you, Mr. Gray. That will be Exhibit 21-1.
Thank you, Commissioner. Commissioners, prior to this hearing, we circulated to the witnesses a set of reform proposals regarding funding arrangements, financial reporting and prudential requirements and regulation. Operator, please display the first page of the propositions, which are tab 111 of the bundle. These propositions include proposals to link funding to the costs of meeting needs for the first time. Doing that will impose accountability for the way funding is calibrated and spent and will inject stability into the funding arrangements for the long term. The critical proposition in this regard is proposition FF1, Commissioners. The proposals we make can accommodate the measures that we recommended to you in February for mandatory minimum contact times and skills mix ratios in residential care. Our proposals are ambitious and will require care and time to implement. Measures to ensure continuity of care in the meantime will be needed along the way. This will require a governing entity to adapt the new arrangements during their implementation where the need arises and to refine them over time. As originally provided to the witnesses, there were 19 propositions relating to funding arrangements and consumer contributions titled FF1 to 19, and then 8 more relating to financial reporting and prudential regulation titled PR 1 to 8. Commissioners, in the lead up to the hearing, we've reconsidered certain of the propositions related to funding and in particular user contributions. We will no longer press FF19, and I'm making that statement for the benefit of the parties who've received leave to appear and the witnesses in the hearing so that they can take that on notice. As a result of no longer pressing FF19, there are aspects of FF18 that have been amended, and we also wish to test an alternative to the proposition which is in FF17 subparagraph A. The alternative proposition is that the means testing for user contributions towards the cost of care in residential care could be retained, but if so, the regime for means testing for those contributions must be made fairer. The amendments to FF17, 18, 19 and new FF20 appear in the propositions that are now published to the public at tab FF1 of the tender bundle. Commissioners, with some of the witnesses in this hearing, we'll also be exploring the potential advantages and disadvantages of various financing options. That is, options for improving the ways in which money is raised to meet the funding requirements of the aged care system. The Royal Commission has already done some consultation on financing reform, including, as at 26 August, it's received 33 public submissions in response to a consultation paper called Financing Aged Care, which is published on our website. These submissions were made by various individuals and organisations, including aged care providers, academics, peak and advocacy bodies, healthcare, accounting and financing, and governmental entities. The consultation paper attracted a diverse spread of submissions, illustrating a wide cross-section of views on financing arrangements for aged care. No particular solution has received clear support from the submissions to date. In this hearing, you'll hear oral evidence from a number of witnesses who made submissions in response to the consultation paper, including National Seniors Australia, CODA Australia, the Combined Pensioners and Superannuants Association, Professor Kathy Eager, Professor Michael Sherris, and Mr. Campbell Ansell of Ansell Strategic. We'll be taking up financing options with a number of other witnesses as well. A word about the context, Commissioners. Context in which your inquiry into funding and financing and prudential regulation is taking place is very well known to you. But some members of the public listening in may wish to know more about the topic, and for that purpose we've prepared a précis of basic facts about aged care services that are funded by Commonwealth subsidies and compulsory user contributions. It's available to the public at tab 107 of the General Tender Bundle, and the operator will just display the first page. Now, this document identifies the main categories of services, including services available under Commonwealth Home Support Program, CHSP, that is, Home Care Package Program and Residential Care, and the other service categories. Under the Home Care Package Program, after assessment of a person to one of the 4 levels of funding, the funding is assigned to the individual to spend as they determine in partnership with a provider that they choose, and is held by that provider in the meantime. Under CHSP, funding is paid directly, in effect by a direct agreement, contract or grant to providers for the benefit of older people who've been assessed as eligible to receive that care and who are put in touch with that provider. In residential care, there's something of a blend of these two models in the sense that funding is paid in a daily amount assessed by the provider as appropriate for the care of an individual using the tool that's known as ACFI, the Aged Care Funding Instrument. The money is paid directly to the provider and need not be individually acquitted as having been spent directly on the individual. In fact, it need not be acquitted at all. That précis paper, Commissioners, refers to the volumes of services, amounts of subsidy and contributions paid for each, and the fact that residential care service prices and revenues can be separated into the following categories, which I'll be exploring with Mr. Corduroy later in the day. Mr. Corduroy of Stuart Brown. Those categories are basic living, accommodation and care, and Mr. Corduroy will also speak about administration. Individuals seeking residential care are expected to pay their own basic living expenses, just as one ordinarily does in life. And subject to a means test, they're expected to pay for their accommodation as well. There's also a means tested care fee requiring a contribution to care for people who are above a particular threshold in a means test. And it's on that topic that I've raised that alternative proposition which I alluded to a moment ago, proposition FF20. Over many decades now, Commissioners, a mix of predominantly private providers and some government entities have been subsidised by government to provide care and support. This sector has traditionally been dominated by not-for-profits, but since the commencement of the Aged Care Act 1997, the mix of providers has tended to include more for-profit operators over time. Operator, please display tab 114, Expenditure Constraints and Major Budget Measures. We've prepared a paper, Commissioners, at tab 114, available to the parties and the public, outlining government expenditure constraints over time and particular major budget measures of recent times. As the analysis in tab 114 shows, and we'll go to figure 3, expenditure on a per capita, that is per person basis for people aged 70 and over, has remained quite flat since the 1980s in real terms. And current planning ratios for granting subsidies, importantly, are pegged to that cohort of Australians aged 70 and over. Now, Commissioners, that's a bit anomalous because the average age at which people start to use aged care service is in people's 80s. So the cohort is not best suited to calibrating changes in expenditure for the aged care services. The planning ratios appear not to be delivering changes in expenditure that are well matched to the cohort of people who really need the aged care, those aged 80 and over. The diagram shows that real expenditure on that cohort has been generally falling since the 1980s in real terms. Current funding and administrative arrangements are not appropriately designed to meet the challenge of understanding and responding to increasing longevity in our community, which carries the potential for longer periods of high acuity of need. Thank you. Operator, we can take that document down now. According to the Aged Care Financing Authority, which you'll hear referred to as ACFA, and sector analysts Stuart Brown, to which I alluded a moment ago, the financial performance of many residential care providers has deteriorated, particularly in regional and remote areas, to the point of some degree of crisis in some cases. And not-for-profit tend to perform worse, and so do very small and very large providers. And I'll be exploring that point a little later with Mr. Corduroy of Stuart Brown. The aged care sector is highly varied in the scale, sophistication and operating models of the different providers, including residential care providers. The cost base in different places probably also affects financial performance. In the report produced by BDO for the Royal Commission, it's clear that despite the pressures that approved providers have faced, some are managing to earn sufficient profit margins to provide significant returns on their investment. And if adequate care is being provided, then no criticism can be made of such returns. However, the evidence identified in the interim report of substandard care and neglect suggests that on a system-wide basis, the current system is not well designed to ensure adequate care is provided. As I mentioned at the outset of this opening, there is at present no systemic means by which it can be determined that particular amounts, and therefore sufficient amounts, of public funding intended for care is actually spent on care. More rigorous financial reporting and accountability should provide part of the solution. There are other reasons why reforms needed of financial reporting and of the related system of monitoring and prudential regulation. That's because of the importance of financial performance indicators as a sign of risk to the vulnerable people who are receiving care from providers, particularly in residential care. At present, financial reporting is not timely or regular. Well, it's annual and takes place some months after the end of the relevant financial year. This leaves it difficult for an external observer to identify risks to liquidity and therefore to continuity and quality of care. An additional reason for close government attention is the possible loss of accommodation deposits, now called refundable accommodation deposits, previously called accommodation bonds, which are lodged by some residents with their providers. If the provider fails, then recovery of such deposits is made difficult. There's a government guarantee scheme in place, so the relevant prudential risk is primarily borne by the government, but there are also implications for individuals. Now, operator, if you'd please briefly display tab 11 and just go to page 14 and 15. There's information here reported by BDO in a second report, Commissioners, which tracks a deterioration in liquidity ratios over time. Over recent years, BDO's analysis indicates that liquidity has decreased amongst a significant number of providers to the point where there may be grounds for concern about the recoverability of a large amount of these deposits. Before leaving the context of the hearing, Commissioners, I just want to mention an important submission that we received early in the Royal Commission's inquiry from the Aged Care Financing Authority, ACFA. The Aged Care Financing Authority is not properly so-called an authority. It's in the nature of an advisory and reporting committee. Nevertheless, it's an important body and it's provided some very important material to the public and to the Royal Commission. ACFA's submission of April 9, 2019 is at tab 108 and it provides a useful framework for approaching the issues of concern in this topic and the principles that should inform the approach to a redesign of funding arrangements. The next theme I want to address, Commissioners, is funding for need. It's really that first key substantive set of issues that I identified at the outset of this opening. The surprising truth is that no one can say whether the current levels of funding available for providers for various forms of care is correctly calibrated to the costs of providing high quality care. The current funding system does not seek to establish whether funding is matched to need or the costs of supplying the care that would meet need. Mr. Nicholas Merciades, who's Director of Aged Care for Catholic Health Australia, probably says this best in his statement prepared for this hearing. That's not yet tendered, Commissioners, but the operator is able to display it. And now on the screen we have paragraphs 18 and 19, where Mr. Merciades eloquently says there's never been an objective cost of care study used to determine the cost of delivering high quality aged care services outcomes based on an agreed definition or measure of quality aged care, including quality of life, nor used to inform price setting by government. The current quantum of funding for personal and nursing care largely reflects the accumulation of historic allocations, the basis for which has been lost in the mists of time. That's the end of the quote. Compounding this problem is the fact that the way in which funding levels have been indexed for inflation since the 1990s has meant that funding has not increased from those levels lost in the mists of time, with real cost increases in service delivery inputs. The Department of Health has acknowledged this in response to a notice from the Royal Commission. In addition, compounding the poor indexation method, indexation of residential care subsidies calculated through ACFI has been frozen on 2 occasions in recent years. There have been other interventions by government to reduce ACFI revenues that is, such as 2016 amendments of classification criteria. And indeed there were similar changes to classification criteria back in 2012 as well. Some providers achieve high profit margins while others are making losses under the same funding and regulatory framework. Now, there are many factors which might explain this. One feature of the current system is that providers are left to determine themselves appropriate staffing levels and skills mixes under that vaguely expressed standard I mentioned before. Staffing accounts for about 70% of the costs of aged care. It's also a key factor in the delivery of high quality and safe aged care. As we've previously submitted, there should be mandatory, albeit somewhat flexible for circumstances, staff contact time requirements and acquittal of staffing costs. This will no doubt result in higher funding, accompanied, as it must be, by public accountability for expenditure on care. Reforms in the area of reporting, transparency and verification or acquittal of expenditure on care will in turn provide a foundation for a different approach to setting funding levels for aged care. I'll ask the operator to display a schematic, which in very broad terms is not intended to be prescriptive at all, but in very broad terms it describes the concept. So providers are funded to provide services, and the reports they make about their care expenditure and the acquittal of that care expenditure can in turn, following the loop around through the bottom of the loop, be used by a body which conducts a process independent of executive government to review that data, work out what the costs of providing high quality care are, and either set or advise on funding levels. That then can, in effect, cause government to fund at the correct level and to for the system to obtain contributions from users at the right level, in turn resourcing providers to provide the services, and so the loop goes on. Now, the regular reporting has other potential uses which are off to the side and which are equally important to the proper functioning of the system, and I'll leave it there. This broad concept will be explored with witnesses in the hearing, and it'll be explained how that loop can lead to better calibrated funding over time. Home care funding is based on 4 fixed levels of funding, as you know, Commissioners, and these too have historical origins. The home care package program is underfunded in the sense that the number of packages are rationed, as you well know, And I won't go back over all that information that we traversed only a week or so ago. But as you know, there's a large waiting list for people to receive packages to which they're assessed. Now, many of those people are receiving services from CHSP, but that puts pressure on activity limits in the funding of CHSP providers, which is supposed to be providing an entry-level service. At the same time as the home care package program is underfunded in that sense, it's also overfunded in an individual sense, at least on average, because there are accumulated unspent package funds in the hands of providers now estimated to exceed $1.1 billion. Now, there's a reform before Parliament which might result in the system of payment of home care package funds being converted to an arrears-based system, but that won't solve the problem of unspent funds as we understand it. We'll explore that with government. The reason why it probably won't solve the problem is that that just will shift where the account is held. At present, the account is held by a provider on behalf of a client. In the future, under an arrears-based system, the account will be held by government, but the phenomenon of an unspent fund or unspent package funds will still continue to be subject to the same set of incentives. Whether grant funded by individual package or budget, or funded by case mix, which is another alternative funding method, in all cases we submit that the funding that's provided must be to a level to ensure the provision of services in accordance with assessed need. Now, currently in residential care, providers are left in effect to themselves to interpret and manage the delivery of care under the revenues or using the revenues they receive from ACFI and other sources. However, all residents in aged care deserve a more reliable system they can have confidence in. As we've submitted in our submissions on program redesign on the 4th of March, reform requires funding that must be available for all who need services, not just those who happen to receive a subsidy under the current rationed program. And further, the total amount of the funding, composed of government funding and any user contribution that's available to resource those services, must be at a proper level to meet the particular needs, calibrated to the costs of those services. A mechanism to achieve this has never yet existed in Australian aged care, but some such mechanisms do exist in other sectors, Commissioners. The closest analogy is hospital case mix funding. And in this regard, the role of the Independent Hospital Pricing Authority, IHPA or EPA, is important. EPA uses data to classify patient admissions in a way that relates to the needs of patients treated in hospitals and matches those to the resources required by the hospital to treat the patient. And it sifts a vast amount of data and is able to reach conclusions on a system-wide basis about those things. Later in the hearing, the CEO of EPA, Mr. James Downey, will give evidence explaining these processes and giving us insights into how they might be adapted to the aged care context. Independent pricing of aged care could then be used as a foundation for case mix funding, a case mix funding mechanism of the kind developed by a team led by Professor Eager of Wollongong University, perhaps. Now, that mechanism or model is currently in government commissioned trials. The mechanism is known as the ANAC, Australian National Aged Care Classification Model, ANAC. Using resources of this kind, there should be an alignment of funding with need at both the individual and system levels. First, at the individual level, there should be an assessment of the person's functioning and needs, and I refer Commissioners to our proposition FF11. The assessment may generate a plan and a budget for purposes of funding services for that person. That's one approach that could be used. See FF6, which in our submission is best suited to certain aspects of care at home. Or there might be a tool which, with a reliable level of accuracy, could convert the assessment to a particular level of case mix adjusted funding for the person, and that particular level will have been determined on a system-wide basis from an aggregation of data along the lines I suggested a moment ago. And in this regard, Commissioners, see proposition FF7, which in our submission, at least at present, is best suited to residential care, although there's the possibility of some such model being developed for home care in due course. At the system level, Commissioners, the matching of funding to individually assessed functioning and needs must be underpinned by reliable cost data drawn from across the system. An official body called in our propositions an aged care pricing authority, see our proposition FF1, should review available information and conduct studies to ascertain the costs of aged care services, including differences in costs which arise in different places, that is in different regions depending on remoteness, and should decide upon appropriate benchmarks for the costs of supplying the relevant services up to a high level of quality. These benchmarks can be used to determine the levels of funding, whether made up of public funding or private contributions to an extent, or more probably a mix of those. The levels of funding so mixed that are appropriate to ensure providers can meet their costs, both direct and indirect. Now, I mentioned indirect costs. This is a point raised by Mr. Corduroy, we'll hear from this afternoon, and we've expressly addressed that in our proposition FF2. Importantly also, Commissioners, the level of funding will have to take into account the need for providers to make a reasonable return on their investment. This process can be regarded as determining appropriate prices for aged care services in light of the costs of providing those services in an appropriate manner and to a high standard. So the prices in this context are a combination of the levels of the subsidies and the user contributions, giving us an overall level of the money needed to provide the service, and we're calling that a price. The need for a mechanism linking funding to appropriate costs is particularly acute in residential care, but it's also relevant in home care. The above measures will help to ensure that the assessed levels of care and support are available for all, but Commissioners, they will take a great deal of time and effort to implement. A transition plan, including immediate measures to improve quality through an increase in staffing levels, is going to be required in the meantime, and we address this at our proposition FF10. Commissioners, the Stewart-Brown Aged Care Financial Performance Survey Sector Report, and that's a quarterly report, shows a mismatch between revenue streams and associated costs. Professor Eager told you in Melbourne Hearing 3 that government funding for care should be required to be spent on care. She added that if care and accommodation funding streams were kept separate, this would increase options available to care recipients who could then take their care funding to a range of different accommodations. Professor Sverrisson also supported, in that same hearing, separate care and accommodation funding streams to provide for a system that's more responsive to recipients' needs in a more sophisticated way. Beg your pardon, that was in Adelaide Hearing 2, Commissioners. These pointers, and I'll be exploring this with Mr. Corduroy, underline the need to conceive of costs and revenue streams for care separately from costs and revenue streams for accommodation. And the acquittal requirement is, there's a stronger case, a far stronger case probably, for an acquittal requirement in the case of care as opposed to accommodation. I'll say something more in detail about accountability and reporting shortly, but at the outset I must make it clear that we do propose that acquittal measure for care expenditure. In a residential care setting, this will entail ensuring that providers report their care expenditure, of course. That's FF12, Commissioners. And in turn, along the lines of some of the additional purposes that were identified in the loop diagram shown to you a minute ago, improved acquittal will open the potential for creating incentive mechanisms to encourage innovative improvement in care delivery. Another way of looking at it is that there might be the possibility of adjustments or the withholding of adjustments if certain benchmarks are not met. We will ask regulatory economist Professor Flavio Menezes of the University of Queensland about this and other topics later in the hearing. Reporting will also serve as a monitoring mechanism to ensure that providers engage the right levels of appropriately qualified staff for their mix of residents under the mandatory requirements to provide staff, which we recommended in February. In home care, currently proposed legislation that I mentioned a moment ago is important in that moving to an arrears-based system of payments for home care should provide a golden opportunity for proper expenditure accountability for home care funds. Government should only remit the amounts that providers have already expended for support and care of home care package holders. That's what arrears payments means. But not only that, government can take the opportunity to require reporting of that expenditure on types of services that have been provided, giving the system governor insight into how the program is performing. I'll now outline further propositions for the management of the new funding arrangements that will be tested with the witnesses in the hearing. There are funding mechanisms that are going to be required in identified so-called thin markets, that is markets where there's not a workably competitive market at all. Sometimes there's no market whatsoever, and we've addressed that in FF4. Under our propositions there, we've referred to the government body exercising system management functions, defining and identifying those markets, and then funding interventions that might be required, such as additional loadings of funding, or indeed commissioning or identification of service providers of last resort to fill gaps. This issue has been identified in other hearings, including the Broome hearing, Mildura hearing, Mudgee hearing, and Sydney hearing 4. And it was a proposition in Sydney hearing 4, as you'll recall, HC6F. Where there are thin markets, the pricing authority may authorise loadings, and if that's insufficient, direct commissioning may occur. Now, obviously where thin markets exist, interventions are needed, but even outside circumstances where there are geographically thin markets, there might be competitive market concerns. That is, there might be the lack of a workably competitive market for a particular category of service, and there might be a particular vulnerability for the consumers of that service which justify economic regulation. This topic's dealt with in our proposition FF3. As I mentioned before, in residential care, it's useful to conceive of revenue streams and services separately relating to costs of living, rent, additional services, and care. Now, in respect of some of these, there are stronger arguments for economic regulation than others, and the report by Professor Menzies is not necessarily supportive of economic regulation extending to all. We'll be exploring this topic with Professor Menzies later in the hearing. One interesting issue is whether accommodation prices should be regulated. In many cases, the government already has a role in setting accommodation charges by reason of the subsidies it provides towards accommodation costs for so-called supported residents. They are residents who pass the aged care means test threshold for accommodation support. Such subsidies, which are known as the accommodation supplement, are provided to about 40% of residents in the system, or provided for their benefit to the providers of residential care. Currently, the amount of that subsidy appears to be somewhat arbitrary, Commissioners, and it's applied on an effectively uniform basis regardless of location, although it is calibrated to whether there's been recent refurbishment of the facility. The Royal Commission obtained a report from Frontier Economics authored by Professor Stephen Gray at the University of Queensland and colleague Dinesh Kumareswaran on models that can be used or could be used in this regard. We didn't ask Frontier Economics to opine on the appropriateness of applying the model they've developed to that particular context, but it is a model that might be available in that context. The new pricing authority that I've spoken about already could also be made responsible for determining appropriate modes of interventions in the absence of workably competitive markets for particular services. And these, as I've mentioned, could include greater amounts of funding loading or direct commissioning. Now, Commissioners, at FF11, as I've mentioned, assessment is developed in our proposition there. It's got to be clinically robust, obviously, and we would say predominantly independent, although we don't wish to preclude the possibility of a blurring of the lines between assessment and consultation with providers to this extent. Professor Li-Fei Lo in the home care hearing made a cogent proposal to the effect that assessment should continue while consultation with local approved providers is also occurring, so that assessments can be finalised after it is known what particular services are available to an individual. The next point is that from assessment, as I've mentioned earlier, there's a number of mechanisms available to convert the assessment into a subsidy level. And we've got FF5 commissioners, which is a block funding mechanism, which is proposed for certain services, in all cases falling into the category of social support, respite, and assistive technology and home modification. And we've also got individualised bundles or packaged funding, FF6 and FF8, which seems especially suited for care at home, where there's a market from which the person wishes to choose services. And of course, we've got for residential care the proposal for case mix with supplements at FF7. FF7 and 9. Commissioners, I'll move to the topic of accountability and prudential and financial risk management. I'll ask the operator to display the propositions again at tab 111 and to briefly display the propositions in regard to prudential regulation, which begin at PR1. Thank you, operator. So the prudential regulation section begins at page 18. PR1 is our proposal for more stringent and regular financial reporting. PR2 is our proposal for stronger information gathering powers, which would, for example, enable random audit. PR3 is a continuous disclosure requirement, filling a gap in the current regime where the requirement to notify of particular events is fairly restrictive and not timely enough in its application. PR4 is a requirement to report on arrangements by which, in effect, the entire undertaking of providing care is outsourced to another entity. PR5 is a liquidity regime by which there is a proposal to empower the body that's going to be exercising prudential regulatory powers to finally calibrate a regime that is designed to identify when providers are running into risks, when they have poor financial management, in particular of their accommodation deposit balance. PR5 is an equivalent proposal in relation to capital adequacy, and PR7 and 8 are propositions relating to regulatory powers and the capability of the regulator. Now, I mentioned a minute ago when I was speaking about the liquidity requirement, the balance that providers hold of accommodation deposits. This is an important issue. It's not the only issue by any means in the context of prudential regulation and risk management, but it is an important issue. As we've said in PR5, the prudential regulatory body could have power to impose more prescriptive liquidity requirements than are currently provided for under the Aged Care Act regime. These would apply to providers holding refundable accommodation deposits and accommodation bonds, ensuring that such providers are able to repay them promptly as and when required without jeopardising their financial viability. Stuart Brown have recommended to the government that a minimum level of around 15% under a risk regime should be imposed, and I'll be asking Mr. Corduroy about that later in the day. There may be scope for a more graduated approach as we've suggested in PR6. I beg your pardon, PR5. PR5. It's a very significant matter, Commissioners, as you've heard previously. The amount of accommodation deposits held by residential care providers is estimated to be over $30 million. At the same time, there needs to be a rethink of the form, scope and frequency of reporting more generally. Timely access to that information is critical to good prudential regulation and informs the assessment of the risk to quality and continuity of service. Now, we understand again that Stuart Brown has made recommendations to government about improvement in reporting so as to require the identification of corporate structures in which a provider is embedded, identifying the basis of intercompany loans and other transactions that might have prudential consequences, and to report on material changes in ownership. These recommendations, again, I'll explore with Mr. Corduroy. They have a lot to commend them. I'll move now to transition direction governance. Commissioners, as you know, aged care services are essential human services, and they're services on which more than 1 million people rely. At the higher end of need, it's literally a life and death matter whether the service will continue to be provided. More than 200,000 people in residential aged care homes literally rely on aged care for a roof over their heads, and other people at the higher end of need in the home care package program also rely implicitly on receiving that care and on continuity of care. While urgent action is needed to ensure the continuity of these services in light of concerns raised by some of the analysts, that's got to be done in a way that doesn't interrupt far-reaching reforms. Urgent action should be carefully designed to assist and not impede the attainment of the longer-term reforms. Research done for the Royal Commission points to increased funding being an essential element of the required response. The Royal Commission has obtained a report from the University of Queensland, which is at tab 14 of the bundle, which shows that there's probably little additional efficiency to be gained from the way the aged care system is operating as a whole. So on average, providers are, according to the University of Queensland, efficiently spending their money on care outputs. In addition, I've mentioned BDO several times already. In their report on the profitability and viability of the aged care system, they suggest that significant numbers of providers are, to use their expression, not viable. Although the sensitivity of that conclusion depends on the extent to which those accommodation deposits are treated as either non-current or current liabilities. If they're treated as current liabilities, then the situation looks far worse. And if they're treated as non-current liabilities, then the situation appears better. Now, I'll ask Mr. Fielding of BDO about this later this afternoon. He's made an assessment that about 80% of those RAD balances, or accommodation deposit balances, should be treated as non-current liabilities. But even on that basis, on the metrics BDO is using, they've identified about 10% of residential care providers as not being viable. And I've mentioned Stuart Brown, of course, already. And in particular, we have the most recent quarterly report of Stuart Brown at tab 61 of the bundle. And I've mentioned ACFA, or the Aged Care Financing Authority, and we have their most recent annual report, the 8th report into the sector, at Exhibit 20-1, tab 7. Now, on the other hand, Commissioners, Frontier Economics, who were also engaged by the Royal Commission to provide advice, they have considered, they have performed an analysis, and they consider that, generally speaking, average returns have been adequate to result in continued investment in the sector over recent years, although there's been deterioration in the last couple of years. And that's an important report. It's a report that acknowledges, however, that the sector is very, very variable in its sophistication and in the returns that are being earned by different segments of the sector. Now, I'll say something briefly about equity and the potential for greater contribution and support by the community of extended public financing. The Royal Commission engaged Flinders University to conduct research on these topics, and the research, which is at tab 22, provides some indication of what the community values about aged care, and some indication that the community as a whole is willing to ensure a system of high quality supports and care is available to all, and in doing so to devote substantial public funds and more private contributions to achieving it. Now, surveys of this kind are always going to be open to statistical issues and disputation about the context and questions, but this is a valuable indication that you Royal Commissioners can take into account in informing the recommendations you ultimately make. Operator, if we could please go to page 34. We see in the figure on page 34, that's page 0034. If we just go to the next page, please, Operator. Thank you. If we go to the graph at the top, we see there that, interestingly, Commissioners, what's valued most about aged care in terms of defining its quality is being treated with respect and dignity, far and above all the other metrics. And as Flinders notes in its report on an earlier page, I think it's page 0032, we won't go there, but this is actually a more significant matter than being empowered to make decisions about care. And Flinders make an observation about that being interesting because of the implications it might have for continued movement in the direction of consumer-directed care. If we go to page 0040, we've got indications in the data described in these graphs of a willingness in the public and in the various cohorts of the public to contribute more to home care to avoid having to go into residential care. If we go to page 0044, we've got an indication of the willingness to make user contributions of a higher level to obtain higher level residential care. And finally, if we go to page 45, please, Operator, we go to a graph which describes the analysis of the data relating to willingness to pay higher taxes. I beg your pardon, it's not a graph, it's a table. But I'll leave it there. I'll move to the next point. User contributions, Commissioners, do play an important role in overall funding arrangements. They make a significant, although small by comparison with public financing, contribution to overall financing. We propose a simplified process for the imposition of contributions from people to access aged care, and these are addressed at FF 13, 14, 15, 16 and 17, and we've amended 18. In FF17, we proposed the abolition of a means-tested care contribution in residential care. And the principle behind that was that while people receiving residential care should pay for their daily living expenses and provided they have the means their accommodation, care is different. The community would expect, in line with the universality of access to medical care at public expense, that care in a nursing home also be financed from public sources. So that's the principle. But balanced with that principle is another principle concerning access according to need and provision according to means. And under that principle, there should perhaps also be some contribution to the cost of care from those who have the means, thus to that extent lightening the burden on public revenues. And there's an intergenerational aspect to this principle perhaps. The generations of taxpayers to come will, over the next few decades, bear a proportionally increasing burden to finance public revenues of Australia compared with an increasing cohort of older people who are no longer contributing to the tax base. This is known as a deteriorating dependency ratio, and the rate of deterioration is particularly acute when compared against growth in the numbers of people over 85. And I won't ask the operator to display it, but there's information on this in the Royal Commission's background paper 2, in particular at page 3, and there are graphs on the deteriorating dependency ratio on the foot of the page. Commissioners, if a user contribution regime is retained for care, then the current means test needs to be reviewed and revised. And in new proposition FF20, we've identified distortions in the way the current means testing arrangements currently operate. They're explained in detail in the text under that proposition. In short, the means testing arrangements have a disproportionately harsh impact on people of relatively modest means and single homeowners compared with people who have greater means. And I won't display those propositions now in this opening. I want to bring the opening to a close, but those are now available to the public at tab 111. I'll move to my penultimate topic of sustainability and stability in the sense of aged care financing. All these required improvements, on top of meeting forecast increased demand based on demographic profile of the community, which would entail increases in funding in any event, are going to cost a significant amount of money. Aged care has never been financed from a dedicated source. Its funding allocation for each financial year is based on forecasts in forward estimates in each federal budget, and it's finalised in the budget prior to the relevant financial year. As such, it's subject to variation for reasons other than the need to fund high quality and safe aged care, such as fiscal pressures. And we prepared a document at tab 114 on government expenditures on older people in relation to other programs as well, just for the sake of rounding out that's actually the constraints document that I mentioned earlier. That's fine. Thank you, operator. Bearing in mind the pressures on aged care funding, we will be exploring options in this hearing around the future financing of aged care. A critical issue in thinking about this is the question of what the money is intended to pay for. The main focus of any new financing arrangement should be on the cost of care. Accommodation and additional services should largely remain private costs, supplemented as necessary through the welfare system or initiatives such as the pension loan scheme. The approaches that we're looking at could be considered in three main categories. First, financing from within the current system of taxation and co-contributions, which is essentially business as usual. That could involve changes to tax rates or the tax base and changes to means testing. A subset of this approach could involve an earmarked levy like Medicare. Now that would be a major departure. The next option we will explore with witnesses is a form of social insurance through compulsory contributions to a hypothecated account or a fund held outside the Consolidated Revenue Fund. Social insurance can be publicly or privately managed. There are a number of variations in terms of how these schemes operate, including who's covered, the forms of care that are covered, and whether the scheme is run on a pay-as-you-go basis, as in the case of Japan and the Netherlands, or builds up reserves for future costs, known as a pre-funded basis. The third option is additional insurance and savings products linked to current superannuation and retirement incomes arrangements. These could include combined deferred annuity and aged care insurance products, superannuation-linked savings or insurance schemes, or insurance to cover for home supports. These could be voluntary or have some aspect of compulsion or incentive to encourage take-up. While the Commission's focus has been on the financing of a universal entitlement of care, we're mindful that access to aged care might be enhanced if people had access to enhanced savings and insurance options. We'll explore some of these possibilities, which include an expanded pension loan scheme, easier access to reverse mortgages, or gap insurance for additional discretionary services. And of course, a future model for financing aged care could include a combination of all these approaches. Chair of the Future Fund and Australia's longest serving Treasurer, the Honourable Peter Costello AC, will give evidence on Wednesday explaining the reluctance of successive governments and Treasury officials generally to dedicate or hypothecate public revenue to particular purposes outside ordinary budget processes. We'll explore whether there's a valid case, however, for doing so in the case of aged care. It might, for example, instill public confidence that there'll be a system of aged care sustained and financially supported into the future, protected from fiscally driven alteration by the government of the day. It could enhance the confidence of providers and potential new providers contemplating entry into the sector, thereby lowering the risk premium attached to investing. We anticipate that former Treasury Secretary Dr. Ken Henry, AC, as well as Professor John Pigott, will support a hypothecated levy and will explain their reasons. One very important sustainability issue is the proper support for people providing informal care, that is unpaid care. This was a focus of the Royal Commission's hearing in Mildura last year, and it receives increased attention in our funding proposals in the form of a dedicated suite of respite services to be funded independently of the primary care recipient's package of entitlements. Respite must be accompanied by coordinated access to carer supports such as training and psychosocial supports. What's the magnitude of the funding requirement? Well, it's difficult to say, and this is only of indicative value. Deloitte Access Economics has done some modelling suggesting that reforms to raise the level of staffing in residential care to what's known as a 3-star standard, comparable with benchmarking by the Centres for Medicare and Medicaid in the US, and thereafter within a 2-year period to move to a 4-star level would incur additional costs by 2050 of 0.3% of GDP, or an additional 20% of the projected baseline aged care budget. That is 0.3% of GDP and an additional 20% of the baseline aged care budget to move to 3 stars, and then 0.5% of GDP or an additional 33% of the projected baseline aged care budget to move to 4 stars. Now, it's also worth considering whether some saving might be achieved if over time proportionally more people remain at home to receive support and care there rather than entering residential facilities, and even a delay in admission to residential care could entail savings. However, it's very difficult to predict and model this particular phenomenon. On a related note, Commissioners, I have to correct a reference I made during the opening of the home care hearing on 31 August at transcript 8813. I referred there to a figure reported by the OECD of Australia having 19% of its population aged 85 and over living in residential care, and I compared this to certain other rates of institutional care reported by OECD countries. These comparisons based on OECD data were and are in figure 9 of research paper 2, prepared for the Royal Commission by Flinders University and published on the Royal Commission website since January. Flinders University has, since the home care hearing, prepared an amended version of that paper, which has now replaced the original version. It raises doubts about whether the comparisons in figure 9 of their report are on a like-for-like basis. It includes this qualification of the comparisons between OECD countries, and I quote, "The Australian data received by the OECD reflects all residents during the financial year, whereas most other countries report the number of residents at a single point in time. Using point-in-time data for 30 June 2018, Australia's percentage in this figure would be around 13.9% for people aged 80 and over, and around 4.5% for people aged 65 and over." End quote. Even so, Commissioners, it does remain clear that Australia is relatively high in its rate of institutional care in the rankings of developed countries. Finally, Commissioners, I just want to say a few things about transition and direction and the need for proactive and adaptive system governance. Consistent with its origins, aged care today is a piecemeal collection of subsidy programs rather than a coherent system based on consistent organising principles. The current design involves the provision of ration subsidies to levels that appear to be largely based on fiscal considerations, or at least open to change based on fiscal considerations. And the design relies substantially on market forces and the hope that regulatory monitoring will maintain quality and safety. Consistent with a limited conception of government's role in oversight of the way services are delivered, there's only a rudimentary and general financial reporting system and monitoring by government of the financial management of providers. An ambitious program of long-term reform is needed to achieve a coherent and high-performing system to be funded and financed accordingly and backed up with rigorous prudential oversight and regulation. But if this is to be done, far-reaching changes to the governance of the system will be required. The Commonwealth Government took over full administration and funding responsibility in this area in 2012, but in our submission has not yet assumed a proactive system governance role. It should do so now, either directly or by appointing a dedicated body to do so. This role will involve careful, phased implementation of the reform program. And as I said right at the start of this opening, those reforms may require refinement as they're implemented, and they're not intended to result in a static set of arrangements. The only certainty is that active and competent system governance will always be required to adapt the system as necessary to meet unforeseen developments. Commissioners, at the following tabs, I've tendered 12 statements from witnesses who will not be called to give evidence at the hearing, but whose evidence is nevertheless very important to the conclusions you might reach. Tab 82, Professor Henry Ergas. Tab 83, Professor Halmar Sverrisson. Tab 85, Mr. Benjamin Feek. Tab 84, Ms. Julianne Mitzi. Tab 75, Mr. James Underwood. Tab 77, Mr. Sean Rooney. Tab 76, Mr. Darryl Price. Tab 78, Mr. Nicholas Brown. Tab 79, Mr. Patricia Sparrow. Tab 80, Mr. Gerard Hayes. Tab 94, Mr. Bernard Gaston. Tab 86, Mr. Peter Colhagen. Just in closing, Commissioners, that is in finishing the opening, I should say, the Royal Commission are currently seeking submissions from interested individuals and organisations on whether capital financing arrangements are appropriate and sufficient for the future requirements of residential aged care, and whether there are potential improvements to these arrangements that should be recommended. Details on how to make a submission on that point are available on the Royal Commission's website, and it's not intended that this hearing will delve deeply into that. Commissioners, I understand that there'll now be a short break.
Yes, we might have a very short break at this stage, just to organise a few logistic matters.
The Royal Commission is temporarily adjourned. The Royal Commission is now in session.
Mr. Gray, I understand that there might be some appearances to be announced.
I understand that also, Commissioner.
May it please the court, Mr. Free here. I appear with my learned friend Mr. Dighton for the Commonwealth.
Yes, thank you.
Commissioners, I appear for the State of Victoria. My name is Holt.
Yes, thank you, Ms. Holt. Thank you. Mr. Gray?
Thank you, Commissioner. I call the Honourable Paul Keating. Mr. Keating's already seated in the witness box.
Yes, thank you. Thank you.
I'm dispensing with any application to administer an oath or affirmation.
Yes, I think in the circumstances and the nature of the evidence, that's appropriate.
Thank you. Mr. Keating, thank you very much for coming along to speak with us today. Can we start with your thinking at the time you first entered government? What was the thinking around policy for providing for older Australians aged care at that time?
Well, I had a, by 1983, when I became Treasurer, at least a dozen or 13 years to think about some of these issues, including aged care. And I first got involved with aged care, of all things, on the Bankstown Municipal Council Geriatric Committee in 1970. Where it became very clear to me then at the time that there was absolutely no assessment by the Commonwealth about eligibility for aged care assistance. And in those days, nursing homes were being run mainly by not-for-profit organisations, and people were admitted to nursing homes, I'd say probably a third of whom should never have ever been in one. So we had, ambulant people who were able to get about, who were in a room maybe of 4 people, some of them critically ill, and that was the environment they lived in. So the thinking at the time was to try and create a level of care which became low care residential, a level of care, what became the so-called Hostel program, to get people out of expensive nursing home fees and costs, and the environment as well. And so I, at the time, in opposition, helped. And these were days when there was a lot more give and take between the parties. This is all before 1975, before the dismissal. With Bill Wentworth, who I think was Minister for Social Security, in encouraging the then government to move to a low care residential system. And I kept an interest in that from a distance until I became Treasurer in 1983. And then really my attention was then brought to it in the company of my then colleague, Brian Howe, who was Minister for Social Security, and I might add a very good one. And he and I believed we had to do something completely different about aged care. And broadly, that was keeping people at home and keeping them out of accommodation, specialised accommodation, whether it was residential low care or high care. Right? And so he and I then moved there was no system of geriatric assessments whatsoever. So we first of all established a system where every single person would be assessed. This was the geriatric assessment teams. I think in 1990 I changed the name. People didn't like the word geriatric, so we changed it to the ACAT, aged care assistance teams, where everyone would be assessed, and where through, at the same time, the development of the HAC program, the Home and Community Care program, we're able to establish a system of income and care in the home for aged persons who wanted the autonomy of living at home, the comfort of being in their own surroundings, and etc. So that's a sort of short history of my involvement with it. And of course, income support later was with superannuation come, but that's about a retirement income rather than aged care.
Well, can I ask you about?
Mr. Gray, just before you do ask, we've had a request that we might have you slide back just a little bit so that we can pick you up on the microphone.
Oh, okay. Sure.
Sorry about that.
You're right. No, good.
Sorry, Mr. Gray.
Thank you, Commissioner. Mr. Keating, can I ask you about that, the connection with retirement incomes provision and your ideas for retirement incomes provision? At the time of the inception of the superannuation guarantee, did you have any thoughts about whether that might provide some sort of ability for people to self-fund to some degree, perhaps additional services in the nature of aged care?
I don't think a country like Australia can have any advantage position of income in retirement without self-provision. So in other words, if we rely upon simply the anti-destitution level and quality of the age pension, that's what it would remain, an anti-destitution measure, whereas superannuation was always designed to be built not to replace the age pension, but to sit on top of it. And of course, so two things were in my mind when I started to do this in 1985, which is 35 years ago. My generation would be retiring around 2020, and there would be a big bulge of baby boom people, and that generation would not accept a $24,000 a year age pension. They had a social standard of living that would not be replicated at $24,000 a year, and would have political pressure from many of them for a much bigger age pension. And the issue was then the dependency ratio. And I think this is still a big issue in any discussion about retirement. When I first started to move with the ACTU on the first 3% superannuation case, we had 6.5 people between ages 15 to 65 supporting every one person above 65. In the 35 years since, that dependency ratio has fallen to 3.7 now, and we believe it'll be around 3 around 2040. So when we began this, there were 6.5 people supporting every age person above 65. There's now 3.7, and we're going to be going to 3. And as you know, a lot of the young people now who actually become that cohort, that tax-paying cohort, many have low incomes, they're renters, they start life with a HECS debt if they've been to university, and of course they pay the GST 10% cold regardless of income. So to this cohort, we are inviting them to carry the great body of retired age people, and of course now with the debts of the COVID budgetary subventions. So you didn't need to be a demographer to work out that this was a big problem. This is why I go back to the point I made. I think you can't think about retirement incomes without self-provision. And as you know, I argue that we should, to reach a standard of 70% replacement of the replacement of your last year's salary at work, I believe this requires a superannuation levy of around 12%, particularly now as yields are falling around the world with low interest rates, and of course now so many people have taken money out of superannuation as well. So superannuation is the grease that lubricates the wheels of people's lives later on, where no such lubrication would exist simply by reliance on the age pension.
Was superannuation intended to take some of the pressure off public financing of aged care?
Yeah, absolutely. Yeah. In the intergenerational report, the first report, which was produced in the period when Peter Costello was Treasurer, the Treasury estimated that the call by the pension system would amount to 4.6% of GDP by 2045, from memory. Right? That's currently 2.7% call by GDP and heading towards 2.5.
In addition to age pension, what about aged care though?
I'm sorry?
Was superannuation in your mind capable of playing a role in taking any public financing pressure off provision for aged care?
Yes, because anybody that has an accumulation is in just a much better position to support themselves and do the little things that make life worth living, particularly if they're living at home. So if the aim of the policy was to have more people at home and having them more independent by having a capital sum or an income stream available to them beyond that of simply the age pension.
And Mr. Keating, what's happened since? So if we go back to the 80s, the inception of these measures towards superannuation guarantee,
Well, what happened
about the
since
mid-80s till now?
Well, what happened since? I'm not here to make political points, but what happened here is that the Howard government stymied the last 6 percentage points. That is, in the 1995 budget, the government I led was to pay the second round of what was then called the LA Law tax cuts as savings, not as cash. Now, so 3% of wages would have been paid off the budget into everyone's account, bringing the SGC effectively to 12 percentage points. And then under the accord which the government then had with the ACTU, there was to be a co-payment from the workforce of 3 percentage points. So that would have made it 15. So every Australian working person would have had 15% super by 2001. By reneging on the tax cuts, the Howard government not only cost the 3% commitment to superannuation, but the 3% co-payment as well.
Has there also been an impact not only on the inputs into the retirement incomes system via superannuation guarantee, but also some exogenous factors such as increasing longevity?
Yeah, longevity is a big issue. I think in the superannuation system I was involved in designing, people retired about 66 and sort of, passed away in their early 80s, 83, 84, something like this. But in the 35 years since, we're living about 6 years longer. So what is 83, 84 is now 90, 91. So that requirement, that long tail, simply meant that the accumulation at least needed to be bigger. And I contend bigger than the current provision, which is based on a 9.5% contribution. So whichever way you cut aged care, if people are self-provided and they have a recourse to a reasonable sum of money, bearing in mind that the prorated assets of Australians now, if you divide the pool, which is 2.9 trillion, by the number of workers, which is 12,800,000, it comes out to 230,000 per person, prorated. Now, some people, of course, have got $1 million and others have got 70,000. But when the American Household Survey came out about a year ago, only 55% of Americans could only put their hands on $10,000. So here we are with 230 and basically doubling about every 8 or 9 years. So you could say, notwithstanding the COVID, and we'll see what happens with markets, but markets normally return to the mean. If markets return to the mean, the average Australian would have prorated $500,000 in 9 years' time. That's a big number. And of course, for people who've already got 600,000 or 700,000, they'll have 1.2 million. 1.2 million, even earning 6 or 7%, would bring in 60,000 a year. So 60,000 a year gives you comforts at home. It gives you options at home. gives you livability, that those people wanting to push people back to the age pension, people subject to the age pension Act would not have.
And the more livable at home, the less pressure on demand for residential aged care, based on what you're saying.
Indeed.
Understand. Now, retirement incomes policy, it's got the 3 pillars, the way in effect you established it back in the era that we're talking about.
Pension, super and voluntary contributions. Yeah.
And the home, the home is regarded as a pillar of provision for retirement, for income in the retirement years to some extent.
Yeah.
Could I ask you about the capacity for some sort of pressure to be taken off the public financing burden for aged care in the future, and what your thoughts are on those matters?
Yeah. Well, my ideas about this have changed quite a bit. I have spoken from a decade ago about the need of a longevity levy. That's in addition to superannuation.
Well, just stopping there for a second, sorry to interrupt you, but can you, even though you were speaking some time ago, can you just expand on what you had in mind at that point in time? What does that mean? And
what I had in mind was noting the fact that we are living longer. And the phrase longevity means someone living longer than their age cohort, normal cohort. It's now meant to mean aging, where in fact longevity is a word that refers to a person who's living longer than their cohort, you know. But let's call it an aging come longevity levy. In other words, we would pre-fund through a national insurance system, not superannuation, a national insurance system where the Commonwealth would ensure, would deliver to everyone, say over aged 80 or 85, a calibrated product, which was income support, aged care and accommodation. In other words, the Commonwealth sort of picks you up at age 80 or 85, because by that stage, most people's retirement superannuation balances will have run down, and we are going to live longer. I mean, anyone now born really in the 1970s is likely to live easily past 105 to 110. So if they retire at 65, they've got 40 years in retirement, or if 70, if they retire at 70, they've got 30 or 35 years in retirement. So superannuation would be struggling to deal with that, you know. And so in aged care, what happens to people, I think, in their 80s, this is the 80 to 100 cohort, which we've never had to worry about as a society, but we have to focus on now, is that people lose their confidence. You know, if they have a stroke or they have a heart attack or they fall and have injuries, they lose their confidence. So the idea they're all going to be sharp at 85 or 90, reading their superannuation balances and working out where it plays with aged person's accommodation or the pension is, of course, not likely to be the case for many people. So therefore, I have believed that the retirement system should morph into an aged care system, a long aged care system, where, you know, the children born today are probably, I mean, you can talk to specialists in this field rather than myself, but really upwards of 110. So, you know, does a country plan for this?
Well, it should be something to celebrate, of course,
Yeah,
but I think you're pointing out the...
Or we just don't worry about, that'll look after itself, or you'll get the nonsense from the Treasury, don't you worry about that, we'll pay that out of recurrent income. This is standard Treasury nonsense, right? This is going to be paid for by the 3 people who are left in the system to carry it all, you know.
Under the deteriorating dependency ratio.
Demographic, yeah.
So, Mr. Keating, what are your thoughts now? You said you had been thinking of a longevity levy. Was that to be, in effect, a sort of percentage added on to tax
Yeah, because
dedicated to a particular fund?
you see, a commercial insurer can't insure again across generations. They don't have the flexibility or the capital adequacy to do it. But the Commonwealth can do it. And the Commonwealth is the default insurer anyway through the age pension. So as the Commonwealth is the default insurer through the age pension and can insure across generations, it's the natural candidate to offer longevity insurance. So we pay a levy. Some people might die at 56 or 60, and their contribution funds the person who lives to 95 or 100. It's a classic insurance system.
And just stopping you there for just a second, when you say the Commonwealth is the default insurer anyway through the age pension system,
yeah,
is it also the default insurer in a sense because it is picking up the costs of the health system and indeed the aged care system?
Indeed, indeed, indeed. But
So,
that model is what I call a pre-funding model.
yes.
See, superannuation is a pre-funding model. You make contributions, and through the magic of compound earnings, you produce a large capital sum over time. And in the same way, a longevity levy in an age insurance system would be a pre-funding model. But then you've got issues about people's ability to pay, who should get the funding, how is it levied, what is returned to the Commonwealth, etc. And so I've shifted my thinking to now a post-funding model.
Just before you go to that,
Hmm.
can I just ask you a little bit more about the concept of a pre-funding model along the lines that you just described?
Yeah.
Is it the case that you could have a levy that is not calculated or calibrated to generate significant reserves for payment of future expenditure, but is quite well calibrated just to pay the costs of the year in question or of the next financial year?
Yeah.
Would that
Could work because you're not then postulating that you would have a growing retirement fund like you do in superannuation, just simply meeting costs. But it's costs for a long time. You know, as the country ages, it'll be costs for a long time.
And the provision will have to increase as the demographic.
And given the way in which, I mean, we've got this public debate at the moment where members of the government are opposed to an extra 2.5 percentage points of wages going to superannuation, half a percentage point a year. I mean, in the blink of an eye, you would miss it, you know. On top of that, you would have to then go out and say to them, oh, by the way, we think there should be a longevity levy as a percentage of wages, another half of 1% of wages, to which you'll get the moans from the small business organisations and the violin playing by members of the Liberal Party backbench, you know. So therefore, adding to the pre-funding model of super is, I believe, going to be politically difficult.
Well, you mentioned the possibility of a percentage being added to, in effect, something like the superannuation guarantee amount in what you just said.
It will make a huge difference, by the way.
It could also, just for the sake of argument, if one was to adopt a levy, one could apply it to the taxpayer directly via the taxation system on top of that taxpayer's marginal rate, could one not?
Just didn't quite get the sense of the question.
Well, I thought you were considering in your answer a moment ago a proposal by which employers would contribute some amount to a hypothetical longevity levy. You could also raise the relevant amount through a levy directly imposed on the taxpayer, the employee or the
a bit like the Medicare levy.
taxpayer. Yeah, a bit like the Medicare levy.
Yes, you could. Indeed, you could. Yeah.
But are your concerns about whether that is politically realistic the same as the concerns you've just expressed about an employer-directed levy?
I think my concern is that we live in this wealthy country, but we now have this long tail of unmet services for home care provision, home care services, home care packages. And why would that be? You know, why would somebody need to wait 36 months for a level 4 package, or 24 months? These are aged people, you know, they're likely to die in the period, you know, 24 months. Or I think even level 1 services in some states now are 18 months or more. So in other words,
I'm not sure if that's exactly right, but we understand the sense of.
in other words,
the
the
point.
political system,
There are waiting lists.
the political system is not paying for the waiting lists now. Not might happen now. I mean, we've got this huge backlog.
Yep.
In other words, there are services that have been nominated that are not being provided now. So therefore, while it could be that a levy and an insurance system may more adequately deal with that, if you look at the long lead times in setting such a system up, and also dealing with the backlog that we currently have, where people are not being supported adequately at home, and therefore taking options to move into care, etc., then this speaks about the propensity, particularly by the Commonwealth, not to meet its obligations.
What's the solution?
Well, this is why I think we could go to a post-paid solution. The benefit of that is, let me give you an example. The higher education charge is a post-paid system. These are loans advanced to students on an asset and contingent basis, on an income, mostly an income contingent basis. So if a student goes to university, then leaves, and then has gainful employment, the tax system puts a garnishee on the wages and pays the university debt down, the higher education charge, so-called, right? If in fact that a person had never had any employment thereafter, the loan would never be repaid, never be repaid. So if we were to move and think in aged care of a post-paid system, the Commonwealth could then advance as loans to every aged Australian so much as to meet their needs in support services to stay at home, or alternatively in care accommodation. And in such a proposition, you couldn't think of much political opposition from any quarter, including the Treasury or anywhere, of advancing Commonwealth loans to people, and then those loans, for instance, you would credit, everyone would have an account. Let's give it a name. We'll call it a wealth account. The Commonwealth would advance money to the wealth account to pay for your home care accommodation or aged accommodation, and then upon your death, and no earlier, would there be a credit to that loan account from the estate of the deceased person. So therefore, their bricks and mortar assets or their superannuation, if they've got any residual superannuation assets or cash or other investments, in other words, upon the death of the aged person, the Commonwealth account would then receive a credit from the estate. So in other words, we're not forcing anyone out of their home in old age. We're not obliging aged persons to negatively mortgage their home. You're not asking members of families to chip in and pay for their relatives in their accommodation or their care. And so I think such a system has a lot of advantages. The main one is that you don't have that fiscal bar on the adequacy of funding that's necessary that we do see now with the big waiting lists on home support, home care packages.
Now, Mr. Keating, can I ask about that? Because it sounds a little bit like the reverse mortgages that commercial entities currently make available. Is it more efficient, or is there some advantage in the Commonwealth doing that kind of funding rather than just private financiers?
The Commonwealth could do reverse mortgages. It could establish a funding capability for reverse mortgages easily enough. It's called policy dexterity. There's none around.
Yeah. Would it be seen, do you think, as a sort of a death tax?
No, but it has one characteristic which I think is a positive one, and that is that the assets of the person maintain them in their later life, and the Commonwealth facilitates that maintenance by providing the loans, right? And then, of course, the loans, as I mentioned, would then be credited to their, let's call it their wealth account or their retirement account, their ageing account. And this, to some extent, would deny certain family members a call on assets that might otherwise not be available. Yeah.
I suppose putting on my former hat as a tax lawyer, I can see lots of people trying to make sure that they don't end up having the assets there that can be called upon to repay the loan.
Well, in the event they're not there, the Commonwealth
Picks it up.
Yeah, that's the sort of, it's the same policy as under the HEX scheme.
Yeah.
That is, it's income contingent and it's asset contingent. If they're not assets there, or then the Commonwealth pays. But it's a very nice way of working out what the Commonwealth should really pay vis-a-vis the assets, residual assets of aged persons in superannuation or their bricks and mortar assets, etc. Whereas the problem about pre-funding it is you're trying to second guess all the time how much is needed.
Yeah, no, that's true. But post-funding it has the problem that people would be encouraged to divest themselves of assets before they got into the system.
Yeah, well, that would be an issue, Commissioner.
Yeah.
That would be an issue. One would need to address that in policy.
Yeah.
But I would believe the possibilities of getting such a system up and running compared to the longer run pre-funding option of, say, a longevity levy, which I thought about doing in the 1990s. I was interested in the 80 to 100 cohort, the unprovided for, let's call them the unprovided for, the 80 to 100 cohort. Never had a mention in policy anywhere ever, but I had intended that we would address the longevity issue in some way in the middle 1990s, and that may have been in my thinking then a longevity levy. And that's probably, had I succeeded in winning the 1996 election, then we probably would have had a longevity levy,
Thanks, Mr. Back to you, Mr. Cook.
Mr. Keating, just thinking about what Commissioner Pagani just said, would another variant of something like this scheme possibly involve some sort of security interest on certain kinds of property to ameliorate those risks of property divestments and other avoidance activity, essentially?
Well, I think it's completely competent for the government to think about a set of anti-avoidance measures, in this respect. But you see, I think what the advantage of post-funding does, it provides what is needed. You see, I think if I could say with all regard to the commissioners, I think that the task of the Commission should be to try and articulate what is needed. In other words, that the Commissioner recommends the establishment of an entitlement, and that entitlement should be met. In other words, the Commission should be more worried about the entitlement and the need than it should be worried about funding it. And if that was the case, if the funding could be put back to, say, a post-funding proposition, then the clarity of the policy need is much more obvious.
As a politician, though, do you think that there is some benefit for governments to have a suggestion from the commissioners about how to fund? Does that make it easier, or do governments just not care?
I think so, because the government would rely upon specialised advice of the kind only you can provide by the processes which you presided over. So I think that's the answer. That's in the affirmative. But I think it's secondary to the entitlement and need point. Yeah.
But it might be helpful if the only obstacle was that, it might be helpful.
But, Commissioner, you've got to be conscious of the great Treasury lie. And the great Treasury lie is, don't you worry about that. We will pick all this up in recurrent income and expenditures. Right? The Treasury hates tax expenditures. It doesn't matter what they are. They hate that, whether it's for superannuation or longevity levies, they're opposed to tax expenditures. And they'll always come up with the policy, don't you worry about that. What that turns out to mean is the meagre resources which are spread in certain areas of need, as we're now seeing in these long waiting lists, 100,000 people. In a country like this, 100,000 people do not have adequate support for home care at home. You know? Yeah, it's appalling. And therefore, no, all the ducking and weaving around these measures, I tend to think would become more secondary in a post-funding model, though of course a pre-funding model could work, because the Commonwealth is effectively the insurer anyway through the age pension, as we know, and really only the Commonwealth can insure across generations. So, I mean, it's a classic, like a fire insurance. You know, everyone in the suburb pays their insurance. You know, 2 houses burned down over 10 years, and so therefore, you know, the insurance premiums pay for that, right? It's an actuarial bet, and the actuaries would work out, I believe, that a longevity levy would not be a great amount, certainly in its early years, particularly if it has compound earnings in some way. You know, that is, the system has compound earnings, a bit like any other fund, whether it's a super fund or a government fund. But what is the departmental policy objection to availability of loans? It's hard to object to that.
Except that they might not match the total debt.
They may not match the total debt. Yeah, that's true.
Yeah,
that's your point about avoidance. You know. Yeah. But then a lot of people won't have. I mean, a lot of elderly people don't have assets. They don't own properties.
Yep.
This is particularly true amongst aged women. They don't own properties, and they don't have an independent source of income. In which case, the loans will never be repaid. You know, will not be settled with the Commonwealth.
Yep.
But that's the underlying principle of the HEX charge now.
Yep. Yep. Thanks, Mr. Gray.
Mr. Keating, one other topic, just picking up on something you said earlier about when people turn 80 or 85, that there should be a policy position whereby the Commonwealth, in effect, provides a network of integrated support. That was my word, but you mentioned income, you mentioned accommodation, health, etc.
Yes.
Could you just elaborate on what you have in mind there as an aspirational goal for future policy makers?
Well, it's longevity, medical advances, all the reasons we're living longer make clear that this is a need that we're going to have to meet. What was your express point again?
You mentioned something, and it was my word. I was thinking that it was a proposal for an integrated set of supports.
It'd be an integrated set of supports where the pension, superannuation assets and income would be tailored into a support system where the Commonwealth offers an entitlement of income support, aged care and health. In other words, once people particularly across the 80s, but into 85 plus, let's say people are going to live, younger people are going to live to say 105, from 85 to 105, they're not going to be at work. Even if the current retirement age of 65 is extended to 70, or even people working to their early 70s, the chance of people actually being at work in their middle 80s through to 100 is low. So therefore, the Commonwealth would be the guarantor of their health and lifestyle, their accommodation, any income support they need, and you would need to tailor into that residual accumulation, superannuation accumulations, and other assets that people have. But there's always going to be resistance to elderly people being forced to sell their home, or to negatively
Reverse mortgage?
Negatively mortgage it, or to negatively mortgage it. Yeah. Where I think that this is why I think the post idea gets over a lot of those issues.
And is that why you didn't agree with my proposition about putting a security interest on the home? Because
putting
a mortgage on the home in support of the post funding model.
Yeah, I don't think politically you'll get away with a mortgage on the home.
And this integrated model of support for older people, by referring to tailoring in assets, including superannuation, do you have in mind some sort of possible design whereby a person who reaches that particular age opts into a system of integrated support, they contribute a certain level of whatever assets they have, and they in return are cared for without the distinctions between the welfare system for the pension and the I don't know, aged care for aged care and health.
As a general proposition, that would be right. Yeah.
Thank you. Yeah. Commissioners, I have no further questions.
Yes, thank you, Mr. Byrne. I think you've satisfied all of our questions, Mr. Keating. I've certainly asked the questions that I had wanted to ask, and Commissioner Briggs is.
I think, look, Commissioner, could I say this, that we are going to end up with extended age. I think, I know, my children's grandparents lived to their middle to late 90s. The chance of my children born in the 70s and 80s living past 100 is very high, and children born today will live well past 100, right? So how does a nation accommodate that? How do we think now? If we do know that the dependency ratio is falling, the number of people left in the tax system to support all this is falling. Mm-hmm. Is it then unreasonable that elderly people should rely on some of their assets and accumulations to meet their own costs? Or should that cost be put to those 3 people in the tax system who have to bear the burden of it, But because the argument could be run, well, we don't want any claim on the family home because that's an inheritance issue for the kids, right? But it's a much bigger claim on the 3 taxpayers left in the system to support every person over age 65, right? So this change in the demographic, I think, changes the argument about what is reasonable and fair. That is, to what extent do aged persons with assets and accumulations support themselves. And all we would be doing in a post-paid model is facilitate them supporting themselves.
Yeah.
Yeah.
Mr. Keating, that's been very, very helpful. I shouldn't let the occasion go past by inviting you. If you've got anything else you'd like to say to us, please do.
No, just I think that there's a lot of ideology around. It's actually not actually ideology. It's actually prejudice around about adequacy in retirement incomes and the superannuation guarantee charge. Just that ordinary men and women mostly have never had their savings professionally managed. They put them in a bank and they get 1.2% for them today. You know, bank deposits were what people did, or they bought treasury bonds. And a treasury bond brings less than 1 percentage point now. You know, the Australian super funds, particularly the industry funds, have been earning 8 and 9 percentage points, been earning 10 times the bond rate. So ordinary people have had the benefit of professional management of their money. So they're investing beside the big American funds, the Warren Buffetts of this world. In other words, they're sharing in the professional capacity to compound their assets. The other thing I think which is very important about this is that society should be sharing in capitalism. In other words, that we don't end up with a great divide where the people who have access to debt, leverage, professional advice end up accruing more national assets, more of the national assets, and that we demonstrate to working people that they are not part of it. In other words, if we want a more cohesive society, that the benefits of market capitalism should be extended to working men and women. And what superannuation does is do that. So I think that's a really important factor in the whole adequacy debate about retirement.
Yep. Thank you very much. I think we now need to just adjourn for a minute or two for some mechanical reasons. We'll resume in about 10 minutes.
Thank you. Thank you, Commissioner.
The Royal Commission is adjourned until 11:55 a.m.
Session.
Mr. Bolster?
Yes, thank you, Commissioners. The next witnesses comprise a panel of consumer representatives. I call Mr. Paul Versteege, Professor John McCallum, and Mr. Ian Yates.
Professor McCallum, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do. Mr. McCallum, I think you may be on mute. Oh, sorry, Professor McCallum.
I am now off mute. I do.
Thank you. Mr. Versteege, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Mr. Yates, do you solemnly and sincerely declare and affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Thank you. Professor McCallum, what's your role with National Seniors?
I'm CEO of National Seniors Australia.
And National Seniors is a not-for-profit organisation that provides representation to older Australians, correct?
Yes, it is.
And Mr. Yates, you are the CEO of the Council on the Ageing Australia, correct?
I am.
And you've given evidence to the Royal Commission on more than one occasion before, I understand?
Correct.
And could you tell us what the remit of the Council on the Ageing is in this particular area of funding and finance?
Well, the Council on the Ageing is a peak body representing older Australians in all areas of policy. In recent years, aged care policy has been a key focus for us because of the urgent need for reform. And we've been active across the whole reform agenda.
Mr. Versteege, you're a policy officer with the Combined Pensioners and Superannuants Association, the CPSA. What particular role do you have in that organisation when it comes to these particular issues?
Well, CPSA is a small organisation, and I'm responsible for the policy function within that organisation. CPSA itself represents low-income pensioners and retirees.
And roughly how many members do you have, Mr. Versteege?
I'd have to check on the latest figures, but I believe it's in the order of 21,000.
Professor McCallum, how many members of National Seniors are there?
We have thereabouts 100,000 paid up members and probably a much bigger majority of people who connect with us.
And Mr. Yates?
Well, being a network, a federation, there are councils on the ageing in every state and territory with both organisational and individual membership and supporters. Organisational membership, last time we checked, was around 1,000 organisations of older Australians around the country, and around about 40,000 individuals who connect to us regularly.
Thank you. Can we begin with a question about the consumer perspective of how older Australians and how they would like to fund their care in later life? Professor McCallum, why don't you start us off with that issue?
Well, could I start with the first question on consultation paper 2, which is around households or government? And I think the majority of older people are happy to pay for things, provided it's fair. However, in our survey work, we find that although people know that they're going to live longer lives, they plan for them. When they get to whether they would spend more in later life, we only get 3% of people who would plan to spend for later life. So despite the fact that people are willing to pay, they're not really planning for that. So I think what's really important then is to move to think about what it is that people want and to make sure the financing is directed to what consumers are saying they want to see. And that is particularly around home care. And and care delivered into the home, as well as people who are caring for people at home. So that's important, I think, that we don't lose sight of that. I think one of the things that came out of the Banking Royal Commission particularly was a loss of that implicit contract with the community. I think we're looking to the same thing going on with the Royal Commission, and particularly the COVID crisis and the, if you like, the stress test that came from that people need to be reconnected to the aged care system and get more confidence in it.
All right, we'll unpack quite a few of those issues as we go along. Mr. Vestige, what's your perspective on the perspective of older Australians funding their care in later life? How should that be done?
Well, speaking from the perspective of our members, who, as I said, are mostly low-income retirees, pensioners, the main concern is how they're going to pay for a nursing home if they should need residential aged care. There is generally a very low awareness of how aged care funding works, particularly home care. Although what's now the CHSP is so well embedded in particularly New South Wales, but I imagine other states as well, that is their go-to place for aged care, and of course that has a reputation for low cost to the consumer.
Mr. Yates, what's your perception of the consumer perspective in this area?
There are a variety of consumer perspectives. I'd agree with the points already made, but there are a variety of perspectives. I think our evidence, both direct consultation and working with older people for many years on this issue, is that older Australians, if they're going to be asked to pay more for their aged care, then they want it to be the aged care they want. And overwhelmingly what they want is care at home. They prefer care at home. In terms of if it's residential care, I think there is an aversion to thinking it through, and Professor McCullum has referred to that. But there is a willingness to pay, provided it's seen to be on an equitable basis, and provided that government is paying the proper amounts that it should be paying so that the overall system works properly.
What about superannuation? Do people regard it as a resource to cover the cost of care, or does it have a narrower focus? Is it about income in later life?
Well, we argue that the retirement income system, which includes the pension and superannuation and other private savings, should be focused on developing an income later in life. What we do know is that significant proportion of older Australians don't spend as much as they could because there is a generalised fear of the costs of aged care, and there aren't specific mechanisms for dealing with that. So I think that there is a conversation at a moment around additional products for people with significant amounts of super, remembering that at the moment many people do not have significant amounts of super.
Professor McCullum, reading between the lines in your submission, it seems to suggest that older Australians don't regard their personal wealth, including their super, as a fund for aged care. Is that correct?
Yeah, that's correct. So I think I think we start by saying people don't think about it and don't particularly want to think about it as a negative. But then beyond that, we've got the facts that people don't see their house as a source of income in the future. They don't see it that way. It's something they live in. And also their assets, they're particularly interested in maintaining them, even at the cost of not providing quality care for themselves. And I think that comes through very strongly. We've been working through the COVID crisis with particularly self-funded retirees in that group that you deal with in Proposition 20 particularly. And they're still not willing to release some of their savings or to think about liquidising some of their assets. It's still very difficult for them to cross that boundary. So I think there's a lot of work to be done, talking that through, providing good ways of doing it. There are bad ways of doing it, so that can come in, so people have better care in old age.
Let's turn then to that. Let's turn to that first interface, the means testing interface, where people come face to face with the impact on their finances of the need to get aged care, and particularly residential aged care. Do you have a view about the transparency and simplicity of the current means testing arrangements?
They're relatively complex and they interact across systems, which is a critical problem. I think they become really critical in that group just above the age pension, and that's a point of great pain at the moment. So there's a considerable distress amongst people who are self-funded in that category, and I think there's some good work coming into the new propositions about that.
All right. Well, why don't we bring up a chart, figure 1 from the propositions, which I understand you've all seen. It's on page 13 of tab 111 of the tender bundle. You're each familiar with that table and have probably seen various versions of it in the past, I take it?
Yes.
Yes. Well, let's look at some of the features, and perhaps the first one that Professor McCallum was talking about. The first thing to note is the box in the lower left-hand corner. This is where people have low levels of assets and very low levels of income. If you have an income below $27,840 and accessible assets below $50,500, you're inside that box and you don't have to pay anything, correct?
Yes.
Yes.
And about a quarter of all residents in aged care are in that particular category, correct?
Yes, but that will be changing as the superannuation guarantee group comes through, yes.
Now, let me just correct something. The living fee, of course, is paid, but that's paid out of the pension.
Yes.
Yeah.
Correct. Okay. All right. Now, if we look at the people outside of that box, but within the line that sort of circles the rest of the graph, that's the range of people who have to make some form of contribution, not the full contribution, to the various fees that are payable, correct?
Yes.
And we're talking there about a quarter of residents in residential aged care.
Yes.
Correct. Those outside the boundary who have, in the case of purely assessed assets, around $171,000, or in the case of pure income, have income of around $70,000, they pay basically for their accommodation, their daily fee, and everything that's required to be in residential aged care, correct?
Yes, as I understand it.
Yeah.
Now, Professor McCallum, you were talking about issues around those people just beyond the margins of the first box, effectively the free box. Can you talk us through some of the issues that those people face in the application of the test as it currently is?
Well, they're at the point where they're better off if they can get below it and get into the pension sort of area as well. So that's one of those means test traps that people get caught in, and then it bleeds into, if you like, into the care that's being provided and the testing around that. So people feel they're worse off when they drop into that area than people who are, if you like, on the pension and have all the benefits of that. So there's a sort of great sense of inequity. Now, that's something that I think is typical of most systems where you have testing, but it's something we have to do something about, because I think we do need to keep people with the motivation to self-fund so they can pay for things.
Mr. Vestige, what's your perspective of the people who just sit outside of that first box? What are the barriers that they face and the inequities that they face?
They will, well, our members would fall outside that first book, that's green, first box. Basically because they have to, in many cases, sell their house and fund their part of their aged care that way. And they are often quite dismayed at the fact that you know, their house then turns out to be a lot, and it can comfortably pay for accommodation bond. They then find that the leftovers are also going to be taxed, if you like, to pay for care fees. That comes as a nasty surprise. It's not insurmountable. It's not perceived as unfair once it's explained, but that's how they interact with the means testing at the moment.
That the Royal Commission's propositions paper identifies three issues at the margins of this these particular means testing arrangements. Let me run past you each of those. The rate at which the value of additional assets above the $50,000 barrier in that vertical axis, the way it impacts on entitlements is quite considerable the closer you are to that limit. Would you agree with that?
Absolutely, yeah.
And the view that we have taken in the propositions is that that impacts disproportionately on the disposable income of people that are in that margin, that where they have assets of just over $50,000, maybe up to $100,000. Not very much at all, but the impact on their contributions is quite considerable. Can you give us an example of that?
Yeah,
Mr. Vestige?
Yeah, the people sitting just outside that box, often as a result of the sale of their home, find that they have to pay most of their pension in daily living costs. Then there is the accommodation payment, the care fees, and most of their income is gone. And in some cases, people might find that they can't actually pay the fees are charged, and they come in. They have to apply for hardship arrangements, and that, of course, is not very good for their self-respect, because they don't view themselves as poor and in need of charity, if you like, especially when it's called a hardship arrangement. The fees just outside that green box are the same, or not the same, but in very large chunks, regardless of whether you are have some assets that can be tested to when you have quite considerable assets to be tested. So that if people find out that is perceived as unfair, it doesn't stop them, but the main concern is often not funding, but it is something that is perceived as unfair.
The next problem or issue I'd like to raise with you is people who have assets of a value of between $171,000 and $500,000. As you go up from $171,000 to $500,000, the changes to your entitlements change in a way that's quite different from people who have significantly greater assets. Would you agree with that, Mr. Yates?
Yes, I would. In fact, we have issues with both the complexity and the fact that at lower income levels you face greater challenges, but at higher income levels you don't, and asset levels you don't. And it's too complex. People don't understand it, and although they accept it when they have a need for care, it means that the burden is unfairly distributed.
And finally, the effect on the marginal tax rate when you factor in all of the liabilities of people in or around this area is quite significant when they have a low, the closer they are to the free box. Would you agree with that, Professor McCallum?
Yes, I would, and I think what we have as strong evidence of that is during the sort of February through to June period, people whose income had been affected by COVID and the collapse of the economy and interest rates and pretty near anything, people affected by that have felt the pain of falling into that group very strongly and very distressed by it. So that's just evidence to support that.
Mr. Vestige, the capacity for people that you represent to get proper financial advice about these issues, how much of a challenge is that?
Well, quite often people don't get financial advice. They interact directly with a residential aged care provider, which is also encouraged by the fact that within the area that they live, typically there are, even if it's a very densely populated area, there might be 10 or 11 nursing homes. So there's not all that much of a choice. Their selection will be to ask around and see which home has the best reputation and try to get into that. That's the type of advice they will get. As to financial advice specifically, I think a lot of people don't even consider it because they don't consider themselves to be wealthy enough for that to be of benefit to them. If they do, quite often they end up with a financial planner with a specialisation in aged care or a claimed specialisation. But quite often, I would almost say invariably, that financial planner has a relationship with one or more aged care providers, so that the advice that they would be getting is potentially tainted.
If we could move on to proposition PF20, which I understand you've each had an opportunity to have a look at. Do you have anything that you wish to say in response to it? Perhaps Mr. Yates, you first.
On the face of a limited examination, given we received this very late, this looks like a better way forward than the earlier propositions and the current system.
Professor McCallum?
Look, I think it's really one way of easing what we see as a big problem for the group. You identify being caught in that middle. And I think the approach to it with means testing and so on really does need to allow people, as I said, to continue to fund their own retirement and not to say, well, I'll go back to the age pension because that's an easier way. So I think we're really very supportive of it. And I agree with Ian Yates that we've just had a quick look at it this morning.
Mr. Vestige?
Yeah, we support certainly the principles underlying that proposal. I noticed there's all that much detail that would enable you to compare it in dollar terms with what we've got at the moment. But the intention is certainly much better than the effect of the current system.
Yeah. Yes.
Let's turn then to the vexed issue of the home. As a matter of principle, how should someone's home be treated when it comes to assessing their assets for the purpose of funding aged care? Mr. Yates?
This is an issue that attracts a huge debate. From an economic point of view, the value of the home is relevant to the assets, but then it depends how you then set the asset test. I would observe that for people who currently the home is taken into account in residential aged care testing, that because only the first 171,000-ish is taken into account, there is an inbuilt inequity there. If we're going to have the home, which we have been sympathetic to in the overall assets test, firstly, you have to look at how much money you want to leave people so that are not affected. But secondly, you need to make the proportion of the home value common. Now, David Tune in the legislative review recommended the full inclusion of the assets test, of the home in the assets test, but other alternatives would be to have a fixed proportion of it so that it's the same proportion with varying asset values.
Mr. Vestige, do you have a different view?
I'm not sure whether it's different altogether, but obviously, certainly for our members, the main asset they have at the time that they access residential aged care is their own home. So they are very concerned what is going to happen with it. There is an acceptance that if they don't need it to live in, then obviously it should help to fund aged care. At the same time, there is a wish to pass on some of their wealth to children, and both those things are very important. I think the current arrangement of an accommodation bond or refundable accommodation deposit, as it's called these days, is a good one, because it accommodates both those things. You pay for your own accommodation in aged care, and you have something at the end of your life to pass on. Inclusion of the owner-occupied home in any means testing for anything, for pensions or aged care. Our main concern there is that people need to maintain their housing security until the very end. And a lot of people are in houses that will not support them if they develop mobility issues or other issues associated with a deterioration in health. So we're very concerned that any attempts to access the wealth in the owner-occupied house, that should not happen before people are in actually secure housing, that is in housing where if they develop mobility issues, they can still stay until it really becomes untenable. That sort of sums up our position on that.
Great.
I think before you go, Professor McCullum, we might bring that graph down so that we can see your face again. That graph could come down, please. Thank you. Professor McCullum?
Look, it's very interesting that the bequest motivation has been maintained in terms of housing at a time when people also help their children with the first homes in ways that didn't happen decades ago, and also typically help them with their HECS or so on, and their education. So that I think is a conversation that has to be had. It's a difficult conversation. We know that since 1980 or so, when they were talking about putting the house in the assets test. I think one of the big factors here, and I'll stop on this, that there will be a growing inequity, social inequity across divisions in Australian society because of the really unusual growth in the value of houses in certain areas of Australia and amongst certain communities. So I think that's a factor we have to take into account.
Let's just change the direction slightly. Older Australians are able to use their home to fund all sorts of things, including their aged care, and they can do that through the pension loan scheme and equity release products. Let's talk about those, shall we? Could you tell us, Professor McCullum, something about the pension loan scheme? Why is it a good idea? Because I think you refer to an example of a couple using it to their advantage in your statement.
Yeah, that's a simple hypothetical example. Why it's important is the home is really an asset, even though it's a place to live, and it should be maintained as a place to live. But it's a bit like the HECS scheme proposed by Paul Keating initially, that with the HECS scheme, you pay back because you're going to earn higher income after you've finished your qualifications. In this case, the asset in the home is what can pay back what for better quality aged care. Now, there are a number of, this is something that has to be solved. We think the interest rates currently provided on the pension loan scheme are far too high to be attractive. But I think also it hasn't really been solved out, and people are not aware of it particularly. So I think that can be done a lot better. I think if we can get that moving, we have some factors that are really important for the economy as we're going forward, which is to, release some of the savings we have in houses so that they are working in the economy, which is another point to make.
Mr. Yates, your perspective on the pension loan scheme?
The expansion of the pension loan scheme, both in terms of how much you can take from it in income and its applicability to everybody of pension age, was a major platform in the 2018 More Choices for a Longer Life budget package that we worked closely with the government on and advocated for this, because it does answer that question. If I'm receiving care in the home, which is what most Australians want for as long as possible, then how do I make my contributions to it? And the pension loan scheme assists that. It's a different situation in residential care, although it then opens up much more the choice between paying a refundable accommodation deposit or a daily payment, because it means that choice is more real for you. I agree with Professor McCullum. The government has not advertised it. There wasn't universal enthusiasm for it in the bureaucracy. It needs to be much more widely promoted. And while I think it needs a more attractive interest rate, we do need to be conscious that if the government were to do it at a very low interest rate, then you would remove the opportunity for any other products out there in the market.
Mr. Vestige, you take a negative view about other equity release schemes, reverse mortgages and the like. Do you draw a distinction between the pension loan scheme and those schemes that you criticise?
No, not really. The pension loan scheme rate, the current rate is below commercial rates already. That is as far as we can see, is the only difference. But the pension loan scheme is very much limited in capital that it can provide, because to use it on a grand scale, on a widespread scale, the government would take on financial risk which they're not keen on, and I think that's why the bureaucracy is not keen on the idea, for that reason alone, and also the pension loan scheme and commercial products, the amount of capital that can be freed up for whatever purpose a person wants it is limited to about a quarter of the value of the house, the assessed value of the house. So that also makes it less attractive than it seems. Because a lot of people think, okay, I've got $1 million house, I will have $1 million to pay for things, and that is simply not the case.
So that brings us to Mr. Keating's proposal that he discussed in his evidence this morning, effectively a HEX-style deferment of the advance by the Commonwealth to the taxpayer of funds needed in respect of their residential aged care. No mortgage over their home, but a loan account which would be settled with the executor or executrix of their estate. What's your initial impression? I gather you've only heard it this morning, and you may not have heard all of it. But what's your overall impression of that sort of approach?
Well, supportive, because it does safeguard the housing security of all the people who need aged care. So that's a good thing. But I would say that such a scheme would have the same financial or even greater financial risk than would a home equity release scheme to pay for aged care. Basically, it sounds like a universal unsecured loan, and I'm not sure that any government would be able to to take that on. I think there's a practical issue there.
Mr. Yates?
It's not dissimilar, I think, although not in theory related to home equity, but it's not dissimilar to what the Productivity Commission recommended, about which there was quite a lot of interest in the constituency. We referred to the PC's proposals as a capital-based HEC scheme. Look, I think at the theoretical level, it is certainly worth exploring. To be a little naughty to say the devil will always be in the detail. You know, the government of the day and government since did not adopt the Productivity Commission proposal, but it's certainly worth exploring, I think.
Professor McCallum?
Look, a very quick comment would be these things are very hard to sell because they're very hard to understand. And I think the sort of trouble that we've had with annuities and pension loan scheme and so on would probably be, this one is not sort of so obvious to sell. So I think there is from the consumer point of view, it's a difficult one to get to understand, to have a confidence in.
Isn't that the problem with all of these arrangements? Annuities, deferred annuities, social insurance that involve people interrupting their residence in their home, which is the number one thing in their life other than their family. Isn't that the barrier that has to be overcome before any of these sorts of products or approaches get traction?
Yes, it is. I think people don't see their home as an asset, but as a home, and something that, you know, traditionally has gone on to children or whatever, even though that bequest motivation isn't as strong as it used to be. So I think this is a point I think we really need to make continuously, that this conversation has to be out and going. Particularly, COVID's really stressed these areas, and that's something that says people need to think about what's going on and what they're going to need in later life and what they need to plan for in doing that. That's a slow process we're going to have to go through, but we have to get that out in the open.
Mr. Yates, why has COVID? In what way has COVID brought this out as an issue this year?
Well, look, I mean, again, I'm going to say the overwhelming preference of older Australians, and particularly as they near the potential for using aged care, is to have that aged care at home. So financing that is a challenge, and you need a simple approach to it, and that's why the HECS proposal is worth at least considering. But John is quite right. People don't plan ahead. I think if we had an aged care system that more met people's preferences, in which they had more control over their choices, it would be easier to have the conversation. But as the Royal Commission knows, I've said that we need a much broader conversation in the community about how we pay for aged care. And I think that we need to discuss simultaneously what government's going to pay and what the consumer's going to pay, because the two things are interwoven. If people think that government's skipping out on its responsibilities, there's a greater reluctance to pay than if they think that it's pretty fair all round.
Mr. Vestige?
Well, COVID has certainly reinforced the wish for people to stay at home. A lot of the schemes that you've mentioned, or arrangements that you've mentioned, are very hard to understand, and I think certainly for our members and constituency, that is the biggest barrier. We seem to assume that the introduction of annuity type schemes and things like that depend on explaining it to people, but in many cases the understanding will never be there, and there needs to be a degree of planning on behalf of government to introduce these schemes, as an age pension scheme has been introduced as a fait accompli, where people have to put their trust in the government to make that work. Superannuation, for example, is still predicated on self-management. You have free choice. You can take out money in lump sums, and all these arrangements make it less effective to fund for the essential things in retirement.
All right, we might change direction now and talk about some of the propositions about the way we've structured the way care is funded. And you've each had a chance to have a look at funding proposition 11 about universal assisted access to timely assessment, etc. You'll have seen the propositions 13, 14, 15 and 16 about fees. I was wondering if I could get a global answer from you each fairly quickly about the overall approach in those propositions. Mr. Vestige?
Sure. Look, all the recommendations or proposals, I should say, about Resicare supplements, assessments, they're all supported. I think proposal 16, which is about ongoing care at home, where the proposal is for that not to attract any care fees or personal contributions to care fees. We have a slight problem with that because of the way home care is going to be funded and a limit set to what funding is available to it. We accept that there must be a limit to what home care can cost the government, but the idea that once you reach that maximum, that people should then pay for their own care, either their own pocket if they have enough money, or through home equity. I think that is wrong. When up to that point you have not levied any fees, any personal contributions to fees at all. I think that's inconsistent and it's unfair.
All right, Mr. McCallum, Professor McCallum, sorry.
I think these are very positive in terms of beefing up home care, which is where the consumer interest certainly is. So I think that they're positive in that sense. I particularly note just in the one reference to residential care in those sections, that not reassessing people in residential care when their condition improves is a great positive for, improving people's health and well-being. So that's a big positive.
Mr. Yates?
Yes, agree with that, although we actually raised with you whether that ought to apply in home care as well to create the same incentive. We were generally supportive of 13 and 15 and 16, although if there's no means testing at all, it does mean that you are letting people with substantial resources into the system for no contribution. And I think the other thing we want to say in terms of 14 is that we think that there shouldn't be co-payments for assistive technology and home modifications. We think these are part of a restorative approach, which is in the government's interest to promote and shouldn't have any barriers in it for the foreseeable future.
All right. Can I ask you each, are there any other preferences of the people you represent that are of significance when it comes to these sorts of funding models? Is there something else that you haven't separately addressed with us that you would like to raise? One thing perhaps is consumer choice, the importance of consumer choice. Where should that sit in the sort of framework that the propositions identify?
Could I comment?
Yes, Professor McCallum, thank you.
Look, I think consumer choice is a critical thing. However, it really needs a great deal of training for the service providers, particularly those going in the field, where they actually, to allow consumers to make choices, they have to become advocates for that consumer, not a simple service provider. And we have a lot of fundamental issues in our training of care workers so that we can get to that point where they are actually advocating for people and sorting out things, solving problems, not just coming in and doing a service. So that's a key factor in that.
Mr. Vestige?
We think there should be a greater. There should be more case management. A lot of people are not really able to make the right choices, particularly in home care, which I mean, the evidence is there that the negligible amounts that are spent on nursing services in home care, for example, the enormous amounts of unspent funds that people accumulate. There is evidence there that either the consumers need to be trained or they need assistance from people who know how to navigate the system and who are able to say what people actually need. That is the main issue to us. Consumer directed care is great, but there needs to be the expertise to direct.
Let me put some words that Professor Egar has included in her statement in this area and get your reaction. Professor Egar says individual funding needs to be distinguished from individualised care planning. She adds that individualised models work best for those able to articulate their needs and preferences. People who are not confident or capable of articulating their needs inevitably receive an inequitable share of resources. Does that resonate with, we'll start with you, Mr. Yates. Does that resonate with you?
Yes, firstly to say we certainly support individualised care planning and packages of support. We also indicate in our research, our very active practical research in self-management in home care shows that there are many consumers who can use it and are able and benefit substantially, both in themselves and financially out of it. But we have also supported the Royal Commission's or Council's proposals around care finders, and we have supported independent case management, people who are on your side, which you can use to the degree that you need to do so. We also need to be very careful about how we assess people's capacity. For example, we have a widespread prejudice that says if you've got a diagnosis of dementia, you no longer have capacity. Sorry, but the evidence shows that many people with dementia have substantial capacity, particularly if they've got advocates and supporters in the process for a long time. Overall, let's be clear, consumers have a strong preference to be cared for at home. The system needs to firstly develop that, and secondly, that they want to be partners in their care. They want to have a significant say in their care. And at the moment, many providers are not interested in doing that. And that's a real problem. And so that all goes to capacity to pay. If I'm feeling that I'm getting a decent deal out of this aged care system, I'll be prepared to pay better for it.
Professor McCallum?
I would only add to my point made earlier that we do need care workers to be advocates for people, not just service providers. Add to that the fact that we do need much more community information and ability to pick up that information, which we're not doing very well in these discussions. We've really got to start to build that base of consumer knowledge and awareness of aged care and what it's about.
Finally, Mr. Vestige.
Well, Professor Egar's, what you quoted from Professor Egar is really the point I was trying to make. I think Professor Egar has made it a lot better than I did.
Thank you. Thank you very much for that. Let me just ask you about an issue that stands out as being problematic with where we are at the moment, that is unspent funds. If we could bring up, please, page 63 of tab 10, which is at RCD *9 0388 0111. While that's coming up, unspent funds in home care are quite substantial, as you'll see from the table at the foot of that page, table 6.2. The phenomena won't be news to any of you three gentlemen, but why do we have unspent funds, and what should the Commission do when designing its programs to avoid that? Is acquittal in arrears the way to go, or on accrual? Mr. Vestige?
It's certainly part of it. They're crucial, and payment in arrears are a good idea, but it's not all. Obviously, people, that is the feeling I get when I talk to people about home care, is that they save up for a rainy day. In other words, they don't see their circumstances in which they have been assessed as needing quite substantial care as really prompting them to pay for that care and get that care. And as a result, of course, it's quite possible that they will deteriorate to a point where there will be a rainy day. But really what is needed is a case manager who makes sure that the care plan is followed and that funds are expended as they are made available. Of course, funding HCP packages to a fixed amount regardless of their need is something that I've never been able to fathom why that was ever done.
Thank you. Mr. Yates, do you have a different perspective on that?
No, different. It's not a different perspective. I think we have unspent funds because of lack of individualised care planning. We also have it for the rainy day symptom that Mr. Vestige has mentioned. We should have payment in arrears. We should have individualised funding. We should have a much more diverse way of approaching this, a much more individualised that allows for diversity. But also one of the reasons that it's unspent is because many people still experience aspects of provision in home care, regrettably, as an institutionalised approach into their lives. They're resistant to services that they don't really want and can't always get the ones that they do.
Can I just pose this last question before you answer, Professor McCallum, and if anyone else wants to chip in, I'd appreciate it. Could payment in arrears be just as effective if it is a payment on an accruals basis? Professor McCallum?
Look, I'm not really able to comment on that. I think payment in arrears has the same problem as we have at the moment, in the sense that there's a resistance by some providers to recommend services or allow services that are not within their own payment system. So that still has that sort of problem to it, that you've got to really get into this system a sense that you're servicing people and providing services from wherever, and that's what it's about, and that's where they become their advocates.
Mr. Yates?
Yes, absolutely agree with Professor McCollum. People want to be able to have their direct control and ask for services, and the current system, the IT system, the payment systems mitigate against that. Government knows that. We need to be able to spend the money to fix that, and then we wouldn't have this recurring problem. I think that, you know, there are both, but ways in which the current home care funds could be spent better in terms of consumer outcomes, but there is also room for saving money here, money which needs to be applied to creating more home care.
All right. Before we finish, there was one issue that stood out from your statement for me, Mr. Vestige, and that's about the market for, or the demand for residential aged care being met. And you refer to that in paragraphs 16 and 17 of your statement, where you say that there is an occupancy of around 90% in residential aged care, which suggests that there's quite a lot of unmet capacity. You also refer to the fact that dual approvals for people with home care packages and a residential aged care entitlement at the end of 2019, there were 69,737 of those, of whom 43,000 were waiting for level 3 and 4 home care packages. What does that tell us about the demand for residential aged care as opposed to home care?
I think it speaks to a great reluctance on a wide swathe of the population to go into residential aged care, and it speaks to a distrust of the residential aged care sector. And I can't imagine that things would have improved over the last 6 months. That is really what it says. People are so keen on home care that they will take inferior packages or will even stay on the CHSP, entry-level aged care, waiting for a level 3, 4 home care package, which is supposed to deliver nursing home type care.
It doesn't necessarily mean, and this is the generally understood conception, that people are forced into residential aged care because they can't get access to their home care level 3 and 4 entitlements. There must be some people going into residential aged care on that basis. Would you agree with that?
Absolutely, yeah. It's you can either wait and rely on your informal carer and a little bit of CHSP, perhaps a lower level HCP, or you can capitulate, and sometimes people have to capitulate because they can no longer stay at home, and they go into a nursing home, and that entry could have been prevented or at least delayed.
Mr. Yates?
Yes, absolutely. I'd make 2 points. One is that people do end up having to go into residential care because the package is not available if they don't have sufficient other supports. Secondly, there are people who make that choice. Families very much make the choice, no, we know what the waiting time is for the package, you have to go into residential care. We actively have no waiting lists in residential aged care as a whole, but government has created a huge waiting list in home care, which is keeping residential care occupancy up. I would make the point that there are residential care providers who do have waiting lists. They're not able under the current ACAR arrangements to expand, and we have too many people forced into providers who ought not be in the market anymore.
Professor McCallum?
Just one quick addition to what Paul and Ian have said. I think some people get into nursing homes because their carers aren't provided with respite, which opens up that whole big area there. That's quite a significant factor.
Absolutely agree.
The last substantive question I wanted to ask flows from that particular dynamic, the dynamic at the door of the residential aged care facility. And Mr. Vestige, at paragraph 49 of your statement, you seem to suggest that there are market forces in play that enable prospective residents to drive down the published RAD price and achieve a better outcome. Is that related to this lack of demand or this weakness in demand for residential aged care?
No, I don't think it is. Even though it's 90% occupancy rate, that's still quite high. Any hotel would kill for it. But I think it is simply related to the fact how, or to the practice of having an asking price which is higher than what you're actually prepared to accept. And I think the asking price is usually set with reference to the typical home value, the median home value in a particular area. And negotiations can take place from that, although I'm sure that there are plenty of nursing home entries simply based on acceptance of the asking price that are put to people because they don't know any better. They think they have to pay it.
And as a result of that, you suggest that some more information is needed in that marketplace involving occupancy rates, amongst other things.
Yeah, certainly. Stating what the occupancy rate is in a particular facility when people are looking would help a great deal in prompting people to question an asking price. They really need to understand that this is a real estate transaction, and just as they would ask more for their house when they were selling it, a nursing home provider will also ask more than they are actually prepared to sell for.
typically when you're negotiating with a real estate agent to buy a house, you've got some sense of the market. You know what the house up the street is sold for. When people, usually in a time of stress, go into a nursing home to negotiate, are they armed with any assistance to do that?
I don't think there's a one-size-fits-all answer to that. I think some people are quite canny in negotiating a best price of entry. Other people will just settle for what they can get. And there's also the very important issue of the reputation of the nursing home, whether people in the area speak well of it, and that will also entice people to accept a high price.
Yes.
Mr. Yates and Professor McCallum, is there anything you wish to add to that issue?
Yes, I think people are probably, I have to make the point, better equipped to understand RAD prices than they understand home care. And we've had to fight really hard to get greater transparency in home care funding, which still has a long way to go. There is somewhat more transparency in residential, but my point earlier is, yes, they want to go to the best one, but often they can't get into the best one and they have to settle for a second best. And that's the way the system operates now, and it ought to stop. But, you know, you can actually at least go and find out what published RAD prices are on My Aged Care. It's much harder to understand how your home care funding works.
With the very we're gone over time, very limited time we've got left. Perhaps some closing points that each of you wish to make. And Professor McCallum, perhaps if you go first.
I think we're at risk of the urgent overshadowing the important, particularly with the exposures of residential care through the Royal Commission and through COVID more recently. So we really need to be sure that we're picking up on what is the strong base of care and, if you like, saving money in terms of, instead of paying money, through better respite. And that's spread all over the Department of Health at the moment. There's a carer portal, but it's for people in NDIS. It's not directed particularly at the older age groups. So I think we need to support the things in Proposition 20, particularly around respite, getting technology into the home, getting these things working, and home modifications so that things are working, the base is working, because there will be a COVID effect pushing people back into home.
Mr. Yates?
Look, I'd like to take it up one level and just make the point that I think between reviews such as the Aged Care Workforce Task Force, the costs involved in creating no waiting time in home care, and other improvements that will flow through the Royal Commission, we are looking not at incremental change in aged care funding, but in a order of magnitude change that is really very significant, that we look forward to the Royal Commission making the case for and giving the reform process traction in that regard. That means that there has to be funding from government, huge increases in general revenue commitment, not from within the health budget, but from other parts of government. But it also is likely to mean an increase in a fair and equitable contribution from older Australians. But I'd repeat my point that if we want older Australians to pay more, we have to give them the system they want, and overwhelmingly they want care at home.
And very, very finally and very briefly, please, Mr. Vestige, if you could wrap it up. Thank you.
Sure. I think it's clear to everyone that aged care, particularly residential aged care, needs increased funding levels, and I hope they are going to get it. I also hope that the industry has a session of self-reflection and will come to accept that what has been provided over the past 20 years has been of continuing deteriorating quality. I don't think that acceptance is universal in the residential aged care sector, and I would really call on the sector to reflect on that performance.
Thank you very much. I have no further questions, Commissioners.
Yes, thank you, Mr. Bolster. Mr. Briggs? Yes, thank you, Professor McCallum, Mr. Yates and Mr. Vestige. Thank you for the time that you've put into assisting us. We're conscious of the help that you've given us in the written responses that you've made in considering the various proposed recommendations that have been put to us, and then in the preparation for and now attending the hearing today. So we're very grateful to you, and we thank you very much for all of that effort and your very considered thoughts. Thank you very much indeed. I think I must now formally excuse you from further attendance, and I do so. Thank you.
Thank you.
Thank you.
We're now adjourned to 2:15.
The Royal Commission is adjourned until 2:15 p.m. The Royal Commission is now in session.
Mr. Gray.
Thank you, Commissioner. I call Grant Corduroy.
Present.
Mr. Corduroy, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Mr. Corduroy, what's your full name?
My full name is Grant Hilton Corduroy.
I'll ask the operator to bring up a copy of a witness that you've prepared, a witness statement that you've prepared for the Royal Commission, RCD 9999 0320 0001.
Yes, correct.
Mr. Corduroy, is that your statement?
Yes, it is.
To the best of your knowledge and belief, are its contents true and correct, and the opinions in it opinions which you sincerely hold?
Yes, they are.
Thank you. I tender the statement.
The statement of Mr. Corduroy will be Exhibit 21-2.
Thank you, Commissioner. Mr. Corduroy, would you tell us a little bit about your accounting firm, Stewart Brown, and in particular its practice and activities relating to aged care?
Okay, so Stewart Brown is a chartered accounting firm based in Chatswood, New South Wales. We have some, I think, 9 partners and 60 odd professional employees. In aged care, we've got a fairly significant exposure to aged care. So even though we do general services, we do business services, tax and advisory and corporate services, we also have an audit division and a consulting division, an analyst division, and some 80% or 75% of our fees in the audit, consulting and analyst division come from aged care and community service assignments. And those assignments can be for providers, those assignments can be to the department, those assignments can be for consumers, care recipients. We deal nationally with all aged care providers, probably nationally with over 200 aged care providers, and we've also got a very extensive aged care financial performance survey, a quarterly survey which provides very granular information in residential aged care and also home care packages.
Thank you. And that survey, the Aged Care Financial Performance Survey, commenced in 1995, I understand?
Yes, that's right. It commenced in 1995 and has increased exponentially in all those years since then.
And you're the lead manager for the survey, are you?
Yes, I started the survey in 1995 and we've got quite a team, as you can imagine, but I'm the lead manager in that survey, yes.
Now, your statement prepared for us in April 2020, which we've just tendered, was prepared on the basis of survey results data up to December 2019, is that right?
That's correct.
And since then, there's been one further instalment in reports of analysis of the survey, is that right?
That's correct, for the 9 months ending March 2020.
Okay, so we've got, in effect, up-to-date survey-based information up to the end of March 2020, which you published sometime after March 2020.
That is correct.
Operator, I'll ask you to bring up tab 62 of the tender bundle. That's RHC 900 003 0001. We'll just tab 61. My apologies. Thank you. Now, is this an extract? Well, this is a page in the March 2020 instalment of reports of analysis of the survey?
That is correct, for residential aged care, correct.
Thank you. And if we just ask the operator to just show the cover so the public can see what it looks like. We'll go to page 1. Thank you. Now, can I just ask you a little bit about the structure of the survey, and I'm sure that informs the analysis in the report. Is it the case that, if we just go to native page 7, please, operator. Is it the case that we see here a number of components which you used to build up a picture of the financial report of the sector as a whole, looking at these revenue and expenditure items for each provider participating in the survey?
That's correct. So we'd have, like, say, 190 providers participate in the survey, say subscription-based survey, but they provide us granular information for each of their aged care homes. So, for example, a provider might have 25 homes, so we get this detail in a very granular sense for each of those 25 homes. So, in effect, our survey operates at looking at well over 1,100 homes and getting the financial performance of those, and we can then determine their performance based on a whole series of metrics, both on their geographic location, their resident mix, security mix, the staffing mix, age of buildings, size of buildings, size of their homes. So there's a whole lot of metrics that's included in it.
Thank you. And I should have also allowed you to say you are also looking at home care providers, but my questions will predominantly be about the residential care sector.
Okay, yes.
And roughly in terms of the number of places or beds, as they're sometimes described, what proportion of the overall market or quantity of places or beds are we talking about?
Right, so if we exclude government-owned homes, that's both state and local government homes. We have some local government homes in them, but if we exclude those homes, and the reason we exclude them is because the amount of data they can provide is of a granular level to really benefit the survey. They operate at different metrics. So if we exclude those, we've got probably over 44% of aged care homes are included in the survey.
Thank you. And I'm just going to ask you some questions about the table appearing on page 7. And maybe, operator, if you could just expand table 2 so that it fills the screen, and then it'll be more visible to people who are watching. And I'm sure, Mr. Corduroy, you know this very well. You probably do it without looking at the screen. But there are a couple of, well, more than a couple. There are 6 lines that are highlighted, and they're given a letter. That is, the first line is ACFI result, and that's given the letter A. And then there's everyday living result, and that's given the letter B. And administration cost is C, and care result is a combination of A, B and C, an addition of A, B and C. And then there's accommodation result E and an operating result. And I'm just going to ask you about those components of your analysis of the financial performance of these providers and of the sector as a whole. ACFI result, can we just focus on that for a minute? What is the revenue stream for the ACFI result from, and what's its purpose? And we could, if you just start answering that question, I'll ask the operator to bring up the infographic on page 14, native page 14.
Okay, so in answering the question, we look at the various revenue streams. So ACFI, the aged care funding instrument, is the government subsidy that's provided, which relates directly to the assessment of the assessment of a resident or a consumer's acuity. And so ACFI is a government subsidy. So effectively, the ACFI revenue is by majority a government subsidy. But there's also a means testing component. They call it the mean tested care fee. So based on the metrics of your assets and liabilities, you can be assessed under the means testing care fee. So the consumer will pay a portion of the assessed ACFI. But in
just
the sense, the main revenue is from the government subsidy.
Thank you, Mr. Corduroy. Please go on. Yes. And what's the purpose of that revenue stream?
The purpose of that revenue stream, we'd call it the direct care. So that's where the government provides a subsidy and the means tested care fee given to the provider for the provider to provide the care services as specified under the General Specified Care the care services, direct care services to residents on a basis that they can provide that care if required on 24/7, 24 hours, 7 days a week, and provide those direct care services. The majority of those, of course, are the staffing costs, being the care staffing costs, which be registered nurses, enrolled nurses, carers, allied health, etc. Plus, there's also chemist and medical supplies, incontinence supplies, those sorts of areas that directly affected the care of the consumer, the care recipient.
Thank you. Now, I'll just stop you there for a minute in your explanation of the items on that table, and I'll ask you about what you just said concerning the breakdown of the direct care expenses. And in particular, when you spoke about labour, you mentioned different qualifications of different staff, registered nurses and so on. Now, does your survey capture direct care labour expenses by qualification?
Yes, it does. We capture it both at dollar cents by qualification, and we also capture it by the number of direct care hours provided. So how many hours per resident per day, those different categories of hours worked, those different categories have worked.
And does your survey collect that information at a facility level, or?
Yes, we do. It's connected at each one of those 1,040 homes that are in the survey that have got information that we consider, once we've cleansed to be accurate, is collected for 1,040 homes, yes.
I noticed in this report for data up to the end of March that you've picked up on a change of nomenclature in the Department of Health, and that the Department of Health now wishes to call what used to be called residential aged care facilities residential aged care homes. Is that right?
Correct, yes. So facilities and homes are interchangeable. I think it's moving away. Facilities probably got another context in the communities. I think aged care home is a much more a representative and a better sounding word.
Now, can we go to the next breakdown of revenue and expense items, which is everyday living? What's the everyday living result composed of, and what's it for? Perhaps it's obvious in the name, but I'll ask you anyway.
But it is, and so we almost call that indirect care. So everyday living.
I'll just ask the operator, sorry, Mr. Corduroy, the operator to bring up the infographic on page 17, native page 17.
So what that's coming up, everyday living is the indirect care, we call it, services. So it covers hotel services, which are catering, cleaning, laundry. It also covers routine maintenance of the home, utilities, obviously gas, electricity rates, and it should cover, but it doesn't, administration under the specified services. So we put administration costs to one side. These are the everyday living expenses that a care recipient receives, and it's covered. The revenue stream isn't coming from a government subsidy. The revenue stream by majority comes from a basic daily fee, which is 85% of the single pension, and that fee is applicable to all residents. So it's not targeted towards the acuity level. It's the same fee for all residents. Certain aged care homes have been granted extra services where they can charge an additional amount because they provide extra services over and above, like a better quality catering, cleaning, laundry. And now they can also charge additional services, which is similar. Extra services you have to apply to be in a wing. And again, aged care providers have got the opportunity of charging additional services as long as they can support that those services are of a quality greater than what the normal services are, and that the residents in fact receiving those services. But by majority, it's the basic daily fee, approximately $52 per day now, which is based on 85% of the pension. So the extra services result is that revenue stream less the expenses of providing all those services.
Well, I'll come to that in just a second, but you've got also, well, when you say it's 85% of the pension and it's about $52 a day, it's capped by the government, and a provider is not allowed to charge more for the basic daily fee than that amount, subject to what you said about permission to charge additional fees or the entitlement for some homes to charge extra fees. Is that right?
Correct, yes.
Now, back to the table on native page 7, administration cost. You said there isn't provision in the revenue stream for everyday living for administration cost. Is there provision in the revenue stream for ACFI result for administration cost?
No, the administration cost in the sense is unfunded. In other words, the cost of the provider that isn't particularly targeted to any of the revenue streams.
All right. And then care result is the addition of those three. Is that right?
Correct.
And can we then go to, and it's the addition of those three in the sense that the administration cost is always going to be negative, correct?
Correct. Yes.
So it's always going to come off.
There's always a cost that's going to reduce the care result, yes.
Yep. And then at E, we've got accommodation result. What is that revenue stream from and what's it for? Again, it's probably in the name, but I'll ask you.
Yep. Certainly, the accommodation result is basically all derived for the accommodation cost and the style of accommodation that a care recipient receives when they're in an aged care home. So there's two basic revenue streams in a sense for that. There's the supported resident, which of course over 46% of all residents today in an aged care home are fully or partially supported. And the government pays an accommodation supplement in lieu of that resident being able to, or the care recipient being able to pay an accommodation fee. And then for the remaining 54%, they've got a choice of paying a daily accommodation payment or a refundable accommodation deposit. That comes under the accommodation pricing regime. So the price for that accommodation the provider can dictate the price depending on the style of accommodation and the location, what the rooms are. They can do it up to $550,000, and if they want to have an accommodation price above that, they have to make application to the pricing commissioner. So based on the accommodation price, sorry.
Just to stop you there, that's a figure that you just quoted for a refundable accommodation deposit, a RAD, correct? And there's a conversion rate which would give you the equivalent in daily accommodation payment or DAP. Is that correct?
That's correct, yes. So the RAD or the accommodation price is the main one to look at, and then that's converted to a DAP based on the maximum permitted interest rate, which is a legislated interest rate that changes every quarter. And that's how you convert it to a DAP. And an incoming resident has a choice of paying a full RAD, accommodation deposit, a full daily accommodation payment, or a combination of the two. And again, if they're a supported resident, then the revenue line. So if you're looking at that slide where it says revenue residents and government, the residents amount is what the resident pays if they're not a supported resident, and the government figure is the government subsidy.
And just going to that line, so under accommodation revenue, we've got residents, then we've got government. This is in table 2 on native page 7. How do you derive the line item for residents to the extent that those residents have lodged a RAD as opposed to paying a DAP?
Now, in this table, this particular table, this is purely based on residents who have paid a DAP.
Okay, so you haven't taken into account any imputed
DAP, no, not in this one. Later in our reporting, we might look at an imputed DAP. So for those who are listening, where they pay a RAD, and what would that be if they paid a DAP? So we can then sort of make benchmark comparisons between different homes. But for this one, this particular table is based on the actual revenue and expense items lines.
All right, thank you. Now let's just, and then the operating result is in effect a combination of those results.
Correct.
Now let's just look at some of the developments or the trends or the movement in the figures. You were alluding to this a minute ago, but when we spoke about ACFI result, I think I might have asked you a question later on. I think I asked you, is there any administrative cost component in there? And you said no. Subject to that point, there is actually a positive ACFI result, that is ACFI revenue is greater than ACFI expenditure on this aggregated average basis across the sector on a per resident per day basis up to the end of March 2020. Is that right, Mr. Corduroy?
That is correct, yes.
Yep. But later on, you make the point that administrative costs do have to be taken into account. We'll come to that in a minute. Everyday living result, even before taking administration costs into account, we see that that is in shortfall, correct, by an average of over $8 per day per person. So this is the government capped rate that's equivalent to 85% of the single basic age pension. Is that right? So that is not paying the expenses that, on average, providers are incurring across the residential sector.
That is correct.
Okay. And added to that, of course, is the administration cost. Now, the accommodation result, it's in the black, and that's not even taking into account any imputed value, imputed interest, perhaps, of a RAD. So there's a complexity there, is there?
Correct. It's not taking into account any imputed DAP, and that's a discussion point. Also, it doesn't take into account any administration cost.
All right.
Might I ask a question, Mr. Corduroy, please? And
Yes.
that is, I'm very interested in the 85% being insufficient to fund those everyday living costs. And I was just wondering, when did it become insufficient to cover those everyday living costs? Because certainly Commissioner Tracy and I heard a lot of evidence about inadequate provision of food, for example, from those arrangements.
Right, so the everyday living costs, very good question, Commissioner, has increasingly deteriorated as far as the loss has increased. Probably if we look, and a lot of this could also be attributable to the acuity of the residents. In 2008, just very quickly, in 2008, ACFI came in, the ACFI funding instrument came in. At that particular point in time, we had a hostel at a nursing home system in place, and about 61% of all homes were hostel, so they had lower acute residents, and their average length of stay often was over 7 years. And so therefore the catering, particularly the cleaning and laundry and other needs of those residents was less. Often they ate in the common dining room, often they ate with their family, and they even had a kitchenette. When ACFI came in, the system changed where the providers were almost encouraged to take more acute residents. And so we had a 2008 and 2012 where we had a change in the basis where we had much lower need residents didn't come into aged care homes and higher needs came in. About 2012 was the breaking point. We talk about that area of profitability. At that point in time, it was about break even. The income, the revenue and the expenses for everyday living were about to break even. Since then, as the acuity level of residents and also the changing nature of aged care home where they're wanting better quality meals, better quality cleaning and laundry, better quality services within there, because it's been a fixed price and it's not related to the acuity level of residents, we've seen a continual deterioration in the results in that everyday living from 2012 through to now, and every year it's deteriorating a little further.
Thank you.
Thank you, Commissioner. I'll ask the operator to now put up page 9, that's native page 9. And Mr. Corduroy, you've got here a trend analysis on this operating result, because so far we've just been talking about, in effect, a sort of a cash operating result. That's right, isn't it?
Well, in a sense of cash, I mean, the accommodation still has a large non-cash item called depreciation.
Thank you. Okay. I'll just call it an operating result as you have on the graph.
Yes.
Thank you. And on page 9, you've tracked by ABS, Australian Bureau of Statistics remoteness categories, a declining result aggregate or average result in performance. And it's quite marked that the blue line, rural and remote, is significantly below. It's a step below inner regional, and inner regional is a step below major city. We're interpreting those graphs correctly?
That is correct.
Yep. Now, at the point where there are red figures in brackets, that's an operating loss, but it's not necessarily taking into account, well, it's not taking into account economic value that might be attributable to RADs. Is that correct? A fair interpretation? Yep. Okay, now, could we go please to page 11, operator, native page 11, and we have here moving away from operating profit or loss to EBITDA, earnings before interest, tax, depreciation, amortization, and is it rental?
It's rental, yes.
Rental and restructuring?
It's rental for there's some operators, not many, that have got what we call an opco, propco, or where the property asset is in another entity, not in the approved provider. So they don't have building depreciation, but in absence of that, we put in the rent that they pay to their that other entity that has the building.
Okay, thank you. And you say that that's not terribly common, or it is common? Are there corporate structures where that's the appropriate?
There are corporate structures. Predominantly would be in the for-profit operators who might, for various structural reasons or their own reasons. There could be taxation benefits or other reasons of just ownership. Might have the properties in a different entity. There are some cases where the properties are in a totally unrelated company owns the property, and therefore the approved provider just manages it. And again, those ones they'll be charging rent, and that's why we include them in there. But it's not by majority.
Okay, thank you. Now, when we look at the outcomes in that respect, there's you've put figures up as at the end of March 2020 in yellow, and when I say figures, you put a bar with a figure at the end of it, in yellow for March 2020 and in blue for March 2019. And what's the, is this demonstrating a loss in EBITDA terms that is more pronounced, again, for rural and remote than in regional and major cities?
That is correct. So these ones, just a point of clarification, these are the results at the aged care home level, not at a provider level. So if a provider might have 20 homes, and in those 20 homes, they'll have a number of homes that are running at a loss. So we aggregate this at the home level. We want to see how they're going at individual home level. And you are quite correct that at 55% of homes in the outer regional, rural and remote are running at an EBITDA loss, which is effectively running at a cash loss. And that's greater than you see in the inter-regional and major cities.
Thank you. So this is actually the best cash metric here, EBITDA.
Yes.
And could I ask you about your reform proposal at the foot of the page? In particular, I mean, it speaks for itself. You're saying that in effect they should be block funded, these regional aged care homes, as you've called them.
We are. Regional aged care homes have got certain characteristics. One is they're much smaller homes because of the area they're in. Their pool of residents or prospective residents or consumers coming in is less, in the sense that they've got to have a lower acuity level on average, so they've got a lower ACFI revenue. And their staffing is often more difficult. Sometimes they've got to give guaranteed hours to staff. Sometimes they can't get the applicable staff. So with the accommodation of their demographics and geographics is that they really do struggle far greater than their major city cousins. And we're suggesting that there should be a form of block funding for those homes, because if you typically, as I say, they're small, so you've got a 30-bed regional home, that's very important to that community. If they've got 27 residents or they've got 24 residents, their costs are virtually exactly the same. And so we feel that they should be block funded, similar to the MPS funding scheme.
Multi-purpose service.
Multi-purpose service, sorry, yes.
No, that's fine. And I'm not sure that I understand the proviso that you've made, though. Can you explain it? Subject to financial viability analysis for vulnerable homes. What do you have in mind there, and what would happen if decisions are made that a particular home isn't viable?
Well, there's two a very good question. There's two parts to that we're saying, is that obviously, like, let's just using that example of a 30-bed home, and they had 27 residents, and if they were getting fully funded and they only needed 10 residents, then we're sort of saying there has to be some sort of regime that they just can't, they've still got to try to attract as many residents as they can, rather than just taking, having a reducing number of residents and getting the same funding. So that's the first part that we're putting in, that they've got to be subject to, that they're meeting occupancy guidelines. The second part, which is an important one you're saying too, is that even with this funding model, block funding, there might be some regional providers that still aren't viable. Some have only got 11 or 8 beds in the home, and they're just not viable under any funding regime. And obviously, that's a decision for I guess the government of the day with the local community about what's the best thing for that home.
Thank you. Can I ask about a different segmentation analysis that you've applied, which is size of home, size of facility by bed, by numbers of beds, I should say. And we go, operator, please, to page 13, the top bar chart, figure 6, operating result comparison by size of aged care home expressed as dollars per bed per day. I'll just try to interpret this, and you can correct me, please, Mr. Corduroy. This is, in effect, graduating the survey respondents into size down the left-hand column, and it is showing with the very large yellow March 2020 bars, where there is a negative figure in red and brackets, that there's a very large operating loss for homes of over 120 places on average, and also for homes of under 40 places on average. Is that right? And also,
that's correct, yes.
And also over 100 places is getting up in that ballpark as well.
Yes, we've noticed it over the years that with the different acuity level of residents coming in, there are really two cohorts: subacute palliative end of life, which has got a shorter life expectancy, and residents with high degrees of dementia, where they can't be catered for in an in-home environment. Increasingly in residential aged care, they're the two cohorts coming in, and therefore for the design of a home to be efficient, we're seeing that the homes that are over 100 places, which are typically single level homes, large homes, big areas, are less efficient now. And under 40 places, your capital costs of running those and the cost is just too high. So you can see if we call it a financial sweet spot, is somewhere in the 60 to 90 place home, often multi-storey now on 2 or 3 levels.
Thank you. And can we also, I'll go now to page 14 and 15, where you've got an analysis of the direct care result, or the ACFI result, and you've segmented.
Mr. Gray, just before you do,
yes, Commissioner.
Can I ask a question which may be, it may be naive, and I'm sorry if it is. When you worked out that sweet spot of between 90 and 100 places, is there a particular factor that brings it over into the profitability or return rate rather than the other? I mean, is it related to? I mean, I understand that there are greater numbers of people, but what's the element within that greater number of people that is most at play in the tipping point?
Yes, Commissioner. What we're finding is that the design of homes is becoming far more critical as far as their efficiency and profitability. And the older style homes, which are large and long distances for staff to travel and for the services being catering, cleaning, laundry to be delivered, in the homes now between, say, 60 to 90 to 100 places, it means that they might have a central lift. The movement of services within that home is much more efficient. And also the design of the I won't call it wards because that's obviously a hospital type term, but the design of each of the areas is different. They might have 15 rooms and much more in a cocoon shaped design. So rather than walking down long corridors, as you might imagine some of the old homes are, they're now in a cocoon shape where the direct care delivery can be much more efficient, less travel between rooms, less having to travel visually, more able to attend to residents' needs. So this means that the staffing costs are lower. Doesn't mean that the direct care that they're providing to the residents less. Often their resident cost per day is, the number of hours of direct interaction with the residents greater, but their movements are a lot less, and also the movements of the services, particularly the catering and also the cleaning and laundry, those services are so much more efficient. So it's really capturing now the design and having the design of the homes commensurate to the cohort of consumers, of residents that are in an aged care home. And that's being a lot more efficient now with a smaller one. And I guess the other one is just on a commercial sense, if it's a multi-level, your land footprint is a lot less, and therefore the land component, the cost of the land, is obviously less than if you've got a larger space of land, for a home on one level over a longer area.
So if one were to make an absolutely detailed list of each of the components that make up the cost and expenditures, the cost of cleaning, cost of food, cost of land, cost of staff, cost of particular provision. So you made a complete, total, exhaustive list. You'd presumably see that the marginal increase of each item by each increased person that you've got will vary differently for each item. So the cost of cleaning might be the marginal cost of having 2 people, maybe not all that much different from 3 or 4. How difficult would it be to work out what all of the marginal different elements were by changes to size, to work out which of the elements are likely to be more sensitive than others, and how confident would one be that, as I think you're saying, that it's essentially the combination of the architecture having an impact upon wages bill?
Yes, look, again, a very good question. To break it down individually, it can be done, remembering that one of the other complexities of the larger homes that they've got residents with a whole variety of different acuity levels, whereas the middle-sized homes, they can target residents with a much narrower cohort. In answer to the question about, yes, it can be broken down to that extent, and also we can break down what the design of a home, how it affects the profitability or the return or the efficiency of the home. And we do that in our survey there. We categorise homes by what we call the first 25%, the first 25% of their operating performance. We're not making we don't make judgment calls on quality of care, but the first 25% do. I might have a higher occupancy. The first 25% are very much characterised by having newer builds of homes or major refurbishments where they are actually more operationally efficient in their design, and that allows efficiency in their care delivery. And so, yes, we've done quite a bit of work down that path as you're asking.
Thank you. That's great.
Thank you, Commissioner. And we will get to that differential performance between the top 25 and the others in a minute. Can I just ask you about a trend you identify on pages 14 and 15 of your March 2020 report? You're identifying in the middle of page 14 that the ACFI result in surplus terms, that is the surplus of the ACFI revenues over the direct care expenses, not counting administration, continues to decline in all geographic sectors, with a significant reduction occurring in the March 20 9 months up to March 20. Direct care costs increased by $9.62 per bed day as compared with March 19, the March 19 period. Direct care staffing costs average $147.25 per bed day and represents 81.6% of ACFI revenue. And you've tracked that on a graph, and then you make the point that there's a divergence between underlying cost inputs and the trend in revenue, and you link that to something called COPE indexation. Can you explain that, please? This is on page 15.
Yes. So there's a formula called COPE. I can't remember the full extension of the acronym, but effectively that's the inflation increase that is given on the ACFI subsidy every year. It's a formula that's not just used for aged care. It's used for a number of different sectors, and so ACFI goes up by that COPE inflationary increase. Now this year it's about 1.5%. Last year was about 1.4. The year before 0, 1.14. So in other words, it's going up by different rates. Now in 2012 and 2018, there was no COPE increase, and in other years it's gone up by this inflationary increase, which we're saying is less than what the increase in the staffing costs are. Most staffing costs, as we can see, about 80% of ACFI is a direct care staff cost. Most of those staff costs are based on national awards or based on enterprise agreements, which are based on national awards, and they're going up at a rate, and I don't think anyone would decry increases in the rate of pay for aged care workers at all. But they're going up at a rate of 2.5% to 3.25% per annum, and yet the COPE increase is going up by 1.5% at best. So it's years when it's not there, it's not keeping pace with the increasing in costs.
I'll ask the operator to call out figure 10 and then the funding reform proposal or consideration you've made under there. Just before I ask you about that, is it true, Mr. Corroy, that this COPE indexation method has been in place for a long time, back into the 90s?
Yes, it was, that's right, under different acronyms, but effectively, yes.
And we've seen in evidence from other people that, in effect, the funding levels produced by ACFI are themselves lost in the mists of time, was the expression. And in effect, whatever those funding levels were, any real increase in those funding levels has been affected by this COPE indexation method. Is that a fair summary?
Look, it's a fair summary, and again, it's a bit to do also with the fact that when ACFI first came in, acuity levels of residents in aged care homes are a lot lower. In the last few years, we've seen what we'd call a plateauing of the acuity levels. In other words, an aged care home, if a resident passes away at an ACFI of, say, $180, then they're unlikely to be replaced with an incoming resident of $180. It'll be some acuity lower. And so with that plateauing, we can certainly look from, say, March 17 onwards in particular, is that ACFI the COPE indexation hasn't kept pace, significantly hasn't kept pace, and this is putting far greater pressure on the ability of providers to provide more direct care hours.
And just two things about that. At about that time, 17 affecting the forthcoming financial year, was there a change, was it in effect a pause in indexation? I think you mentioned a zero figure for COPE.
Yes, there was a pause in the 18 financial year, plus and also not compensated, but together with a change in the ACFI basis for certain of the ACFI domains. So funding went down 50% increase in certain domains, and the two together will represent a significant detrimental effect on the revenue stream for ACFI.
Now, in the following financial year, the 19 financial year, was there an injection of $320 million in the final quarter to top up revenues, presumably because of concerns about deterioration in financial performance?
Yes, there was a one-off, we referred to as a government grant. There was a government grant which was based on 9.5% of ACFI. It was basically said to cover 15 months or 18 months, but effectively it was paid in the period late March through to end of June. ACFI was the mechanism of which it was paid. In other words, it was an increase of 9.5% on the ACFI subsidy, but wasn't relational in a sense to ACFI. That was just the mechanism of payment. So it was really we'd refer to as a government grant, a one-off grant that was paid to help compensate providers generally for their deteriorating financial performance.
And is it true that it has no recurrent effect? It hasn't raised the levels of ACFI payments in any recurrent or permanent sense?
No, in effect, no. Because once it was paid, the ACFI, with the base for ACFI on 1 July the following year went back to the amount before that one-off 9.5%.
Now, what's the effect of these events or events like them? Would you describe them as volatility in the funding levels? And what's their effect on the sector and investment plans?
Look, they're extremely volatile. As in 2012, there was no COPE increase, and we saw a significant drop in the profitability of the sector in that particular year. And that announcement from memory came in about May, before the end of the year, before the July increase was expected. Generally speaking, every year there's no pre-warning of what the ACFI amount's going to be, so there's a fair bit of speculation of the COPE increase. There's a fair bit of speculation coming in May and June of what it might be. Very difficult for providers to do any strategy or forecasting based on an inflationary increase that they don't have any visibility over, and that really does increase the volatility of the sector.
And what's the current status of investment planning based on your anecdotal knowledge of all of those connections that you have with 200 providers and so forth?
Look, I'd say it's fair to say that investment in the sector for a number of reasons has deteriorated to be very, very minor. There's, for a number of years under a separate thing, the ACAR round, the government issued bed licences. About 75% were issued to for-profit providers, with the aim being that they will generate new capital coming into the sector. But I'd say in the last 2 or 3 years, we're seeing investment in both areas. We're seeing new investment into the sector of very limited. We're seeing investment by existing for-profit providers into the sector limited. In other words, they're not prepared except for particular, there might be particular circumstances, but a lack of interest in new investment from existing providers. The not-for-profit sector is characterised by they've got much more significant cash holdings, but we're not even seeing in the not-for-profit sector a great deal of new investment to refurbish and regenerate their existing homes, unless they almost have to because of the design and the age of the homes, or they see an opportunity. But the appetite on both for-profit and not-for-profit for investing into the sector, being existing providers or new providers, is not great at the moment. In many parts, part because of the return on investment is poor, and I think part because of this volatility that you've just referred to. It's very hard to have a strategic plan or an investment strategy when you've got so many things that could occur. Could we have a new funding instrument, for example? What's going to happen with the pricing structure? What's going to happen as a result of the Royal Commission? So there's too many variables to allow for a positive impact on investment.
And when an investor, whether debt or equity investor, is considering investing, there's a concept called a risk premium, isn't there?
Yes.
What's the effect of this volatility on risk premiums, to the best of your knowledge, based on your?
Mr. Gray, just before you go on to that, because it's, I think, a different topic, something I want to.
Please.
But do hold that thought. It's a good thought, and bring back that chart, please.
Operator, please bring back page 15. So
in just looking at that chart, what I read it to mean, it shows, I gather, the increase in money going in in percentage terms in those two streams, and one of them seems to be flattening out, and the other one seems to be increasing. The flattening out, has that got something to do with the caps?
Yes, Commissioner, that has. The flattening out, which is the maroon line, that's the ACFI cumulative increase. So that's got everything to do with the COPE increase, because, as I said, we're seeing a plateauing of acuity needs. So in other words, we're not getting more residents coming with higher acuity, therefore higher ACFI. So we can actually now really start to see the impact of the cap, as you say, or the COPE increase.
And is it telling us something about the cap being underfunded?
I believe that's correct, yes. The cost of providing those direct care services, which is the green line, is going up at a much greater rate than now what the maroon line is, as far as the funding, the ACFI funding.
And are we able to draw any conclusions about the underfunding in respect of the green line?
Well, I guess the conclusion there, and that's a very good point, is that if the underfunding continues to occur, it's going to put pressure on providers to be able to have the staffing levels that are even required to meet the direct care needs. I'm not aware of any provider who has reduced their staffing needs. They're certainly trying to maintain it, but obviously if their funding reduces, it's going to put significant pressure to increase staffing levels, which might be what is required from a care point of view. But there's no funding required to be able to do it. So we're going to see increased pressure on providing those staffing levels.
Thank you. And have you seen the paper that was put out by us on expenditure constraints and major budget measures, which I think
yes.
is a document you have?
Yes, I have.
Yep. Thank you. Yes.
Thank you, Commissioner. And I've indeed been covering some of the territory in that document with you, haven't I, Mr. Cordroy? Thank you. Look, I'll just ask you one quick question about figure 10. The green line, the ACFI services cost cumulative increase, that's about 80% driven by staff costs, is that right?
That is correct, yes. By direct care staff costs, not COPE including ordinary staff costs, direct care staff costs.
Thank you. Now, you've made a recommendation at the bottom of what's currently on the screen for reform, in effect, of the indexation method by an addition of 1% over the ABS wage price index, and that wage price index itself is going to be generally higher, maybe as much as twice the COPE indexation method. So this is quite a large increase in indexation you're recommending.
Yes, I am, because the ACFI funding instrument, or the current ACFI, might be ANEC in the future, but the funding instrument for direct care wages for direct care subsidy is very much intertwined with the staffing costs, which is saying about 80%. And so we believe that the inflationary increase should be targeted to a more realistic measure, which we think is the ABS wage price index, which is a quarterly price index that comes out. We've suggested an additional 1%, one to allow for further growth in staffing costs, staffing wage rates. We think it's essential growth, and also hopefully for more increase in staffing hours, and also to compensate providers and therefore then for care recipients for having many years of being underfunded in this area, in the increase in that area.
All right, thank you. Now, you've seen our propositions. In particular, I'm going to refer to FF1 and 2. I won't ask them to be brought up, but they are for independent pricing, including incorporation of indirect costs into funding levels. I take it that in the longer term, that might cover your concerns here?
Yes, correct. But
in the meantime, something of the kind you're recommending here would be an appropriate interim measure. Is that a fair summary?
Yes, look, we based these recommendations that you're seeing it is on the existing funding envelope. There will be, obviously, we hope it changes to the funding model, but that's going to be a period of time. But we feel that these reforms really need to be enacted as soon as possible.
Thank you. Now,
just again before you go on, the expenditure constraints and major budget measures paper on page 2 shows the estimated impact of 2 factors, including COPE, which I see means the Commonwealth own purpose outlays / expenses, showing that over time it's had an impact of about 25%. Do you got any comment about that? Well, first of all, do you remember that?
Sorry, Commissioner, you're referring to me in now?
Sorry, yes, I am. I am referring to you. No point referring to Mr. Gray. He's a permanent fixture.
Okay. Sorry. Yes, I think, well, in answer to your question, I think interpreting your question, Commissioner, is that, yes, the effect is a cumulative effect that there's a deterioration of 25% in meeting the additional subsidy for the staffing costs in providing that direct care.
Yeah. And does that accord with your understanding or analysis of the figures?
That does, very much so.
Thanks.
Thank you, Commissioner. Just back to the risk premium question for both debt and equity investment. Assuming that investments do go ahead to some extent, albeit they may be chilled by uncertainty in the face of funding volatility, is there, to the best of your knowledge, based on your consultations, an effect on risk premia?
Well, I think so. I mean, when the listed entities first, if we're looking at risk, and they first entered the market, they have 3 good attributes. We've got an ageing population, and clearly Australia's we live longer and an ageing population. 70% of the revenue is government funded, and therefore government funded, you think there's a certainty around that. And the third one is this whole accommodation pricing matrix, where that if you got a RAD in, for example, it was government backed, fully government backed, and you didn't have to provide any security for it. So it had three different areas which would reduce the level of risk that someone would any investor would look into. Now, of course, that risk matrix, as you say, or risk premium now has changed because we've seen that government funding policy can change. It can be changing by ACFI, which it has, and they've changed the matrix in some of the components of ACFI. It's changed because of COPE, as you've said, and the mix of the opportunity to from accommodation pricing has changed as well. So these 3 things, I would suggest that the risk profile for aged care has gone up considerably, but the return doesn't compensate, is not commensurate with the risk profile,
which should lead to difficulties to attract and retain investment, and perhaps that's what's occurring. Is that what you're saying?
Look, I think so. If I had to say there's one biggest single thing apart from the normal economic effects is the lack of certainty, legislative certainty. We know that in residential aged care, as we're looking at that now, it's affected quite rightly by in-home care and more packages that are issued for in-home care and greater funding for in-home care. I think most people would agree that that's where where the choice is for people to remain in home as long as they can. So residential care is being impacted by that. That's fine, but there's still a lack of legislative certainty and regulatory certainty, and that more than anything, I think, will impact investment.
I'll just ask the operator to put up native page 18, and this is a similar trend analysis you've done for the revenue stream and the expenses associated with everyday living, and you've made a recommendation as a result of a worrying trend, a deterioration from an already poor position along the lines of the answer you gave to a question asked by Commissioner Briggs a little earlier. And it's very marked in respect of rural and remote residential care homes. You've made a recommendation for an increase of the base amount for the basic daily fee, which is the revenue stream for everyday living costs, by $10 per day, just a flat increase of $10 per day. And again, is that an interim measure pending some sort of longer term solution? Our solution that we're proposing is for independent cost review informing the setting of subsidy levels. Do you accept that as a reasonable idea, or are you more inclined to agree with the full deregulation proposed by Mr. Tune?
Look, I certainly accept that an independent review of pricing is always a good idea, irrespective of how it affects the pricing. And certainly on the activity care side, absolutely. On the accommodation pricing, absolutely. And the everyday living also with that sort of certainty. What we're saying is both an interim measure and a measure that can be incorporated into your independent pricing review is the fact that the providers are not getting a revenue to match their costs. Now, we saw earlier that we had an ACFI surplus, we'll call it, like a direct care surplus. So that surplus is now being used to subsidise, as it were, everyday living, and also to subsidise the accommodation component. So therefore, if we want to get more direct care hours, then we've obviously got to compensate that by having a revenue stream for everyday living that's commensurate with it. I believe a deregulation doesn't mean that we don't still have a pricing commissioner or a pricing involvement to look at the prices and see exactly what the services you're getting for the pricing. But as an interim measure, which I think, Mr. Gray, you correctly termed it as, I think as an interim measure, we need to have an increase in that daily fee by $10 per day. And that would, in the ideal world, that would come from both means tested as well as supported. But we think that in the current climate of residential aged care, that should be by way of government subsidy. And putting our way back to in the 1990s, when we had a different funding model, the government of the day was paying $20 a day subsidy by way of these services under what they call SAM. So we're, in a sense, it's not something that hasn't been done before, but we think it's really vital to do now to sort of ensure that providers are being recompensed for the cost of providing those services, and therefore they're not compensating by cross-subsidising, in a sense, internally on their ACFI revenue.
Just one quick question about a suggestion you've made about the source of the payment, and you've said it should be paid by government. You're referring to that $10. In the longer term, would it be appropriate to have regard to the principle that daily living expenses are generally the sorts of things that we all pay on our own account all our lives, and for those who can pay, whatever the proper level of daily living expenses, whatever that might be determined to be, for those who can pay, they should pay, and it's really just people who can't pay who should be perhaps protected by a topping up by government so as to bridge the gap between, say, 85% of the single basic age pension and the relevant level set by the regulator. Do you think that's a reasonable approach?
Mr. Gray, I absolutely agree with that proposition. We've suggested that there be an interim phasing in period before user pay for the difference. But as a general principle, we believe, and I believe, that the consumer should be co-contributing to their cost of care, and particularly, as you say, in these everyday living expenses which they've contributed to all their life. And therefore, if they have the means to contribute to it, I think the consumer or the care recipient should be paying for those.
Thank you, Mr. Corduroy. Now, I want to go back to a topic I've already raised a couple of times, which is investment and capital investment in particular. Now, there's reference in table 6, which is on page 20, to the accommodation result, and there's a reference under accommodation revenue and accommodation expenses. Under expenses, there's a number of line items. There's one for depreciation. There's also refurbishment. There's also other accommodation costs. There's no reference to a rate of return, a required rate of return on investment at this point in the analysis, is there? But depreciation not being a return on investment, it's a return of investment. What's your position on rate of return or some reasonable return being earned on capital investment, and how should that be factored in to the revenue streams that would be available to providers under a better designed system?
And I think that's again a very good point, Mr. Gray, is that from a provider level, the government is contributing and the care recipient very much to the cost of care. Now, under the consumer choice and moving forward into that area, the consumer should have a choice of accommodation. Now, if they choose for the circumstances, the care recipient has to have accommodation in an aged care home, then the cost of that accommodation has to be commensurate to provide a return for the provider to provide that accommodation and maintain that accommodation to the right standard that's applicable to consumers coming in at any point in time where they come in. So therefore, we very much clearly identify direct care or the care result, as you've mentioned, and the accommodation result. The accommodation result, we think this is where the provider should be looking at being what's the return that they require from an accommodation point of view to provide the accommodation, and within that accommodation to provide the care that's required to recipients. So this is really the area that the provider, I think, should be focusing on, and government policy should be looking at what's an acceptable return. We feel that the metrics for acceptable return is a return on asset, return on the cost of what that asset is. And therefore, what's an acceptable return for the accommodation? Given that today the cost of building is somewhere between, say, $250,000 to $350,000 for a good standard of accommodation. There are some places obviously a lot greater, but we say $250,000 to $350,000 is what's a commensurate return on providing that accommodation. And we think aged care is a long-term investment. It's not a short-term speculative investment. It's not a construction investment. So what's a long-term investment of that? And I think the figure should be somewhere between 4 and 4.5% per annum. Should be looking at the return pre-tax.
Thank you. So in accounting terms, it's correct not to have incorporated a return on capital in this table, but the surplus that results, the accommodation result, on your evidence, should be delivering that 4 to 4.5% return on investment.
I think so. One for two reasons. One, to encourage investment and continued investment in the sector, and two, that the line there you can see refurbishment is a line that we are concerned about. The lack of return to continually refurbishing the homes to keep them at a commensurate standard of accommodation.
Yes, and it's quite low. So gets quite complex, doesn't refurbishment might be regarded therefore as additional capital expenditure rather than anyway. Yes. I'll just ask you this. I won't go to all the text because we're running out of time, but you've made the point in this report also that once there's a allocation of administration expenses across the three revenue and expense streams that we're discussing, that actually the accommodation result is in the red as well.
That's correct.
And you just described that as not sustainable.
No, it's not sustainable from an investment point of view. and not sustainable from maintaining the quality of accommodation. That should someone goes to an aged care home, they've got to get accommodation that's commensurate to what their needs are and what their desires are.
Now, I want to ask you about RADs, refundable accommodation deposits, and their effect on this whole equation and analysis.
Yeah, just a minute though, because I want to ask about these rates of return.
Of course.
So rates of return are not fairly standard kinds of things, aren't they? I mean, if you want a rate of return upon money, then I go to a bank and find out what interest rate they're going to pay on a variety of products. If it's a speculative return, there are markets for these things, and presumably we can work out, and rather presumably there are lists which identify industries or activities, and the return that's expected from those activities and industries at any one point of time. And presumably banks consult them, and investors consult them, and investment advisors consult them, all that kind of thing. And then the question becomes, where within that list would you expect to find this kind of activity? Is that how you worked out your 4 to 4.5%?
We to a certain extent, yes. One of the issues, of course, we've got here is when we're looking at a rate of return, is if you've got an approved provider that provides the care as well as providing the accommodation, they'll have a different matrix, we'll call it, than if, for example, you've got another entity provides the accommodation, and therefore they're wanting to get a return from the approved provider who's providing the care delivery. So we've got a little bit of variation because of those two sort of models. But we've looked at it from the point of view of what's the sort of return if you're investing into accommodation that you'd like to get for a long-term accommodation with a relatively secure environment, given ageing populations, as I say, and government subsidy, what we believe would be a commensurate return. Remembering that the aged care home, if we build a home, what's the effective life of an aged care home? And in many reasons now, we believe the effective life is about 25 years, a maximum of 25 years. And it's not because the structure will necessarily fall down, or there won't be refurbishments in that time, but the nature of what the requirements for aged care home in 25 years' time will be quite a deal different to what they are today. So therefore you'll be depreciating your asset over 25 years, not 40 years or 50 years. And therefore we've got to build into the rate of return an asset being an accommodation asset, a capital asset that's probably going to have a lower effective life than, say, many other industry sectors.
So these rates of returns are obviously affected by all sorts of things. And take, for example, a hotel. You'd expect that the rate of return of a hotel would be largely impacted upon its location, because its location, depending upon things like quality and style and market, will mean that they can expect a certain degree of occupancy, and they'll get a return based upon a whole variety of things, which will include the bed that they make available and the ancillary services that they have, like the bottle shop down below and the cafe. So, and each component of it is likely to have a different rate of return. So the kitchen presumably would need to justify a different rate of return than the bed component. Otherwise, you'd outsource the kitchen component to somebody else who can make a better go of it. How do you factor all of those complications in working out the 4 and 4.5% in respect of accommodation, which has about it not only the bed, but the acuity complications of care?
Yes, a very good question. We've just looked at it from a point of view of sustainability for a sector. So changing the terminology from viability, which might be the short-term viability, what's sustainable? And we believe that in our modelling, that if you've got a 4.5% return, given that you're still making a small of an appropriate return on your care delivery, We believe 4.5% return, which is far greater than what we're getting today, puts it in the realms of being a medium to long-term sustainable, given the unique nature of aged care at the moment, where the RADs or the accommodation deposits are backed by the government, so that in a sense they're unsubordinated debt. A resident comes in, pays a RAD, the provider doesn't have to provide any security for the RAD because the government is providing a RAD, and we've got to factor that in when we're looking at the a rate of return that makes it unique to aged care, residential aged care, and we've sort of factored those together, and we're just basically taking a view. If you were wanting a long-term sustainability, that we'd need to get a return of around about that level.
And can I ask you this question about that conclusion? Is that figure of 4 and 4.5% likely to be the conclusion that most people in your position would reach, or is there likely to be great variability?
Oh, I think there'd be good. When I say variability, good variability. Obviously, different people have a different view of how the impact of RADs are, how you have an imputed DAP, what's the demand for it. I think that like any good discussion, there would be terms. I just take the view that I'm an accountant, and therefore I just look at what's a revenue, what's an expense, and what's the return on that, and what's the assets employed, and basically look at that. I think RADs is a very variable thing at the moment because 46% of residents are supported or partially supported, so they don't pay a RAD. So when we're looking at the rate of return in an aged care home, you've got to think that on average, you're only getting a RAD for 54% of residents, and that's a RAD or a DAP. 46% you're relying on accommodation and supplement from the government, which is less than the commensurate RAD or DAP. So sort of, I'm looking at building is what's the overall result of a home, and if you've got a 4.5% return on capital in the overall result, we believe that that's probably a sustainable return for a medium to long-term investment and to maintain the quality of the home. But I think it'd be open to certain speculation, and certainly economists who've got far greater economic skills than I might come up with a different figure. But I think from an accounting point of view of what's sustainable in our modelling, and we do quite a lot of modelling, we think that's about the rate of return that's required to attract investment and retain investment in the sector.
So the key concept there seems to be that it's the return that's required for a sustainable placement of that amount of money into that kind of activity, rather than necessarily the rate of return that is likely to attract investment.
That's correct. We think that attracting investment is depending on variables outside what we consider sustainability. We've approached this and also looking at our funding is what is sustainable for a provider, and therefore investment that could be part of the investment decision for new providers coming in or existing providers to expand or stay in the sector.
So in other words, it assumes somebody wants to invest in that industry for whatever reason, and it may not be for investment purposes. Your figure of 4 or 4.5% is, well, somebody who's in that industry will need that for that decision to be sustainable.
That's correct. Okay. There might be a number of investment banks who say, and equity investors who say they want a lot more than 4.5%. So we're not speculating on that. We're just saying what's sustainable for an aged care home today, continuing on.
I understand. Thank you.
Can I just take that a little further, but in a slightly different direction? Might it be an option to have a separate revenue stream for profits themselves that might be designed to incentivise higher levels of care, for example?
Sorry, Commissioner, you just cut out a little bit.
I'm probably mumbling, I beg your pardon. Might it be desirable to have a separate revenue stream for profits themselves so that the expected profits would be transparent, and that would give quite a lot of level of certainty, but also it might incentivise improved standards of care, or it could be used, for example, with a higher profit incentive payment for higher levels of care, for example.
Look, I think that's a very good question, Commissioner, and that's how we've tended to design our survey of these analysis, by looking at what's the return for the care delivery, which is very important, and what's the return for the accommodation. And we would say to providers, they need to look at those two results separately when they're looking at their strategic planning. The care delivery is almost immediately, what are they doing, how do they improve the care, what are their strategy there. The accommodation, they need to look at it in a more of a long-term result, but this money, the accommodation result, is to set aside to maintain those homes over a longer period. So I think you're quite right that having that sort of separate delineation, I think, is a good way of assessing the performance.
Thank you.
Thank you, Commissioners. I might take a little bit longer with Mr. Corduroy than I'd anticipated, because we still have some important prudential regulation topics to cover with him. Mr. Corduroy, I'm going to ask you about, I won't ask you too many questions about RADs as you analysed them in your March report. We'll move on from the March report now, and we'll focus on the prudential regulatory proposals. And I understand you've considered those, you've had them for some time, you've been thinking about them. You've got considerable experience, if I may say so, in reflecting on prudential risk monitoring, prudential regimes for aged care and financial reporting. For example, in October 2019, Stuart Brown provided a report to the Department of Health on review of prudential framework for refundable accommodation deposits. That's so, isn't it?
Yes, correct.
And the operator will put that up at tab 103. And I just want to ask you a couple of quick questions about this. You will have seen our propositions PR5 and PR6 concerning the principles for design of an improved liquidity standard and also capital adequacy standard. I noticed that in this review, which is now on the screen, if we go to page 74, that's page 3509, the risk model that you were proposing was a risk model that put greatest weight on liquidity ratios. So that is particularly with reference to balances of outstanding accommodation deposits, what is the ratio of liquid assets, to use a fairly loose expression, to that balance? Is that in essence the nature of the concept of a liquidity ratio?
Yes, so we reviewed all providers who had failed, that there was a calling on from the bond guarantee scheme. And in each case, the ones that had failed through liquidity, not through capital. They'd failed through their inability to repay RADs or their debts, or accommodation bonds going back in the time. So what we felt that's the major, when we're looking at prudential requirements, that's the major prudential risk, is a provider not having the liquidity to meet their debts. We've also, I guess, based it very much on the approved provider level, and now approved providers are difficulty, because if for profits, the approved providers often, the approved providers might be a separate entity that only does the care delivery. In the not-for-profits, the approved provider might also have other business segments. But we've said that all of the analysis has to be done at the approved provider level or the parent entity level. They've got a consolidated set. And we've got to take into account their liquid cash assets, which you say is an interesting term, but we're saying all access to cash, that's a cash equivalents, any financial assets, and a percentage of their lines of credit, and as a result of their total debt. So we provided our analysis not just by looking at RAD debt, but really incorporating what is their other debt, which could be external borrowings, as in bank finance, and could be related party debt, because there might be, the way their structure is, there might be a debt to related party, which is a real debt. So we've said that the primary concern that we think that the prudential regime should be looking for is ensuring that providers have got sufficient capital, liquid capital means, cash assets, to meet their debt requirements. And we've suggested the figure that we can see, and that thing should be a 15% threshold, and that's 15% over all debts. Some other reports, like the Ernst & Young and the Deloitte, they've suggested 30 or 35% of RAD debt, but we believe we need to take into account all debts of that approved provider or that consolidated entity.
Thank you. And that's, in effect, an important input into a risk analysis or a risk matrix, which also includes consideration of other indicators, does it not?
Oh,
such
correct.
as capital adequacy is in there as well, but you place major emphasis on liquidity.
Yeah, we think capital adequacy is a secondary measure, an important measure, but a secondary measure, because capital adequacy depends very much on the structure of the entity. So, for example, a not-for-profit entity has a totally different equity structure than a for-profit. If we looked at 3 listed entities, they've got different policies as far as dividend payment of dividends. And so, therefore, if we look at the return on equity or the capital adequacy of the 3 listed entities, they're entirely different just on the basis of their policy regarding dividends and the like. So we think that doesn't give a full measure, and certainly doesn't allow us to compare for-profits and not-for-profits.
Thank you. So with that modification, and that's still your view that that's an appropriate approach
Yes.
To understanding prudential risk. So with that, I take it you'd modify our propositions PR 5 and 6 to that extent.
Correct.
You wouldn't agree with a separate standard for each of liquidity and capital adequacy?
No, we've just modified to that same thing. I mean, again, we believe in both, but we think liquidity is the main one.
Now, apart from that, having regard to the whole suite of regulatory proposals from PR1 through to PR8, do you have any other concerns about any of the other propositions in there, having reflected upon them, or do you support those?
No, I support the propositions. I particularly support the fact that there has to be a reporting regime to the department or the regulatory body, statutory body, that provides full disclosure of all the things that they require to be able to do the prudential risk matrix, and you've covered those in your paper.
Now, thank you. And on that topic, I wanted to take you to another document, tab 105. In particular, Mr. Corduroy, it's the case, isn't it, that there's complexity introduced into the operating environment here by related party transactions within corporate structures. Now, that's not a criticism that those things are happening. It's just an observation that the reporting regime is totally inadequate to capture the actual economic effects of those transactions. Is that a fair summary? Do you agree with that?
Yes, I do. We believe that to make a full understanding of the prudential regulations, you really need to see it, what we call the consolidated entity, the parent entity, which eliminates all of the related party transactions, so you can see exactly how the parent entity, who might have an approved provider as a subsidiary entity, how they operate. Now, we're not suggesting that's in the public domain, but we're certainly suggesting it should be within the domain of the statutory body that handles the prudential risk matrix.
And what about what's known as operating segment reporting, be that revealed at the approved provider level or at the group level? Don't you need to know what revenues are coming from aged care as opposed to other potentially diversified activities of the same entity or the same corporate group?
That is correct. We believe, based on the aged care financial report, which is what this slide refers to, we've worked with the department to get a much more expanded, enhanced aged care financial report. And we also think for the general purpose financial statements, separate to a discussion about Tier 1, Tier 2, but AASB 8 operating segments, I think is a very important accounting standard that should be disclosed, and that can then be relational back to the aged care financial report as well.
Now, in that October 2019 review, I noticed that you didn't necessarily support moving providers to Tier 1 reporting. Is that a correct interpretation?
Look, that is correct. Just very quickly, Tier 2, which is known as reduced disclosure, the name I think is a little bit misleading. A Tier 2 means you still have to apply every accounting standard, and you have to disclose the accounting standards to such an extent that the accounts aren't misleading. So what Tier 1, the difference of Tier 1 and Tier 2, Tier 1 has additional disclosures. Now, many of those additional disclosures aren't relevant to the user. In fact, they could be misleading to a user. So we're not recommending going to Tier 1 disclosure. We don't believe it actually enhances, but we are saying that there might be certain disclosure requirements that would be benefit to the stakeholders by adopting like AASB 8, which we talked about operating segments. We think that's a Tier 1 disclosure. We think that's a good enhancement. Things about related party disclosures, we think there are certain disclosures that would enhance a Tier 2 general statement, and the Aged Care Act and the department can speculate that can say that you need to have those standards, but we don't believe that there'll be any great benefit overall to transparency. Transparency is a topic at the moment, and we think there's two levels of transparency. There's a transparency from the public. Now, the transparency from the public, if a Tier 1, Tier 2 won't provide a greater level of transparency if you're looking at an individual approved provider, but we think that there are enhancements that can be put in a general purpose financial statement that will improve the public's perception of individual provider. We think for the department, though, they need to get significant additional information, which we think can come from the Aged Care Financial Report, which will include many of the additional disclosures and information that you might get from a Tier 1, or you might even get in additional to a Tier 1 or Tier 2. But we're certainly not in favour of across the board Tier 2 reporting. I know we're only talking residential aged care, but we'd like to see general purpose financial statements for all aged care providers,
including home care providers.
Including
now,
home care and CHSP.
What's the current status of this document? In this document, you've put forward recommendations, or you've worked with the department, you say, to generate reporting of a more rigorous nature along the lines you've discussed. What's the status of this document? Has it been accepted?
I haven't seen. I know that the department's working through it. Certainly verbally, we've worked through it quite collaboratively, as well as obviously in the written document. I haven't, nor would I necessarily expect to get a reply from the department saying they're enacting it. I don't see any particular. I think we've gone through quite a process, but I think that this document can be put into place for FY21, financial year 21, fairly easily. But I'm not sure of the current status with this document. I think it was delayed because of COVID, and because COVID, there was a feeling that this couldn't go in financial year 20 because there's too many other issues that providers were dealing with, rather than giving an expanded reporting framework.
Now, my final question. My final question is about acquittal. In our proposition FF12, we're proposing, that is the council team are proposing, that there be a requirement for residential care providers to acquit their direct care expenditure, that is to prove that they've spent the amounts provided for the purpose of care on care, including staffing. And is there any workability issue, burden issue, any problem of principle that you can see with that proposition? And I have in mind here what you said earlier about your survey picking up hours of labour in different categories at the facility level. Is that proposition an appropriate proposition?
No, yes, it is appropriate. If we use our survey, if we look at our survey how it is, and you look at the ACFI result which you talked about, which has got the ACFI revenue, and it's got the ACFI expenses, which are all the dollars of staffing costs and other costs, and also it's got the direct hours, well, that, to our mind, that would be the basis of your acquittal.
And is there any problem in principle with, in effect, imposing that on residential care providers in return for the sorts of other proposals that we're putting forward about reforming the funding arrangements in the document that you've seen.
Now, all the participants in our survey provide that data now by each aged care home, so it's not additional information that they'll need to provide. They'll probably use what they provide us in the survey. So I don't think it's putting any more burden on existing survey participants. Other survey participants, when they come in, they conform fairly quickly. So I don't think it will provide additional burden. I think what I would always recommend is that providers generally, from our understanding, they're happy to give information as long as they get information back. And if they from putting it in and they start to get more collective information as a whole, this is what the sector number of hours are, this is what the sector costs are, sister returns, I think that providers would really welcome getting information back as well.
Will they be receiving funding? That's
Yes.
the proposal.
Yes.
Now, you've said some people who've come along and joined the survey haven't had that capability to begin with, but they've been able to acquire it.
Correct.
Is that a difficult thing? Does that require much of an investment in order to build the capability for a provider to provide the information to you? Is it provided over the internet? How does it work?
Well, at the moment they provide it. We've got the key to any survey is we've got to have a very clear set of definitions. So we get accuracy. We do a fair bit of cleansing. We still get it. We send out a data input sheet, which is Excel based. Get the information back. We've got quite a sophisticated web behind it. But the reason that we do it this way is that we undergo quite a bit of data cleansing, and so therefore the data cleansing enables us to be sure that we go back. We have many times we go back to providers, even long-standing providers, and saying, in this particular home, this looks out of kilter here. Can you confirm this? Can you do that? The key to it is that data cleansing area. So it could easily be put online, and we've got the structure to put online. We just want to have that ability to really interrogate the data and to go back. Now, we don't audit it, but to go back. But in answer to your first question, how difficult it is to get it, most accounting software now use our chart of accounts almost as their standard software. And we would sort of say that this is information that they're wanting to use and needing to use for their own management purposes. So we're not asking them for something that's outside of what they would really be wanting to do for management. So once we do the mapping, it comes pretty easy.
Thanks, Mr. Corduroy. I have no further questions, Commissioner.
Thank you, Mr. Gray. Mr. Corduroy, thank you very, very much indeed for your assistance throughout the whole of our time, but in particular, the reports that you put in for this session and for giving your time this afternoon has been very, very helpful in clarifying and extending our thinking. So thank you very much indeed for your assistance.
Thank you very much. Good afternoon, everyone.
I think I must formally excuse you from further attendance, even though you're nowhere nearby.
Thank you very much.
Thank you, Mr. Gray.
Next, I call Andrew Fielding. In fact, I call Andrew Fielding and Fahim Kondaka to give evidence jointly.
Mr. Fielding, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Mr. Kondaka, do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? Please say, I do.
I do.
Mr. Fielding, Mr. Kondaka, you both work for BDO and you've both been retained in your capacity as officers or employees of BDO to do work on behalf of the Royal Commission. That's correct, isn't it? I think we might have...
We've just frozen. Sorry, it's just frozen.
I was just asking for confirmation that you've been working under engagement with the Royal Commission and you've prepared 2 reports for the Royal Commission.
That's correct.
Thank you. And I'll be in the main directing my questions to the larger of those reports, or the report dated 21 July 2020, which is at tab 10, please, operator, report on the profitability and viability of the Australian aged care industry. Although I might also ask you a question, time permitting, about the other report. And if we get time, I'll also ask you about the methodology adopted to analyse returns in a report prepared by Frontier Economics for the Royal Commission, and I hope you've been apprised of the particular issues that I might raise in relation to the methodology adopted in the Frontier report.
Yes, we received it on Friday.
Thank you. And BDO has extensive expertise in accounting, analysis, forensic accounting, and skills of the kind needed to understand issues concerning the use of funds on a large scale, including under government subsidy programs. Is that right?
That's correct. We've conducted a number of assignments in that area.
And I understand you've prepared a slide presentation, Mr. Fielding?
Yes, that's correct.
And are you going to show that now to perhaps spend 5 minutes or so giving an overview of that first report? I'm calling it the first report. I'm not sure whether it is actually first in time, but it's the report on the profitability and viability of the Australian aged care industry, tab 10.
Yes, I'll hand over to Fahim to guide you through that presentation.
Thank you.
So if we have the first slide.
Thank you. Thank you very much. If I could have the first slide again, please. The next slide. Just to cover off on the scope of that report, we were asked to analyse financial performance data as presented to the Department of Health, and we were asked to determine the profitability and the viability of the sector. We did have 10 years worth of data that ended in the financial year 2019, but our analysis focused on FY 2018 as that was the last year where we had a complete set of data as for the most part of the report. I would like to note that the results that we've analysed are materially different, may be materially different to what's going on in the current economic climate as well. So please keep that in mind. Today, in 5 minutes, we just want to cover some of the key findings of the report. The first one, just to set the scene, is to understand the model, because I think most of our findings relate to the model. In the core model of the current aged care sector or industry, there are three players. There's the care recipient, there's the approved provider, and the government. The approved provider under the commercial model, and there's details in section 2 of our report if you want to refer to it. Essentially, the approved provider has two avenues of creating value: by providing services or through property investment. And the care recipient obviously receives those services and accommodation from the approved provider. The government plays the role of funding the services and also underwriting the refundable accommodation deposits for the care recipient as well. Where the complexity gets introduced, and if I could please have the next slide, is twofold. One is that approved providers are allowed to undertake non-aged care activities, which is highlighted in the orange box dotted line within our slide in the middle there. Not every approved provider does that, but there are some that do. And then the second area that adds complexity to the model is that the approved provider is allowed to interact with other entities, whether related entities or non-related entities, to undertake the services that they provide. There's two.
I'll just ask, when you keep referring to the model, that's not actually a digital construct or anything. You're talking about an operating model that's commonly adopted in the sector. Is that correct?
Yes, or the structure of the industry as it currently works. So if you and I were to open a approved provider, if you and I were to be an approved provider, this is how it would operate. And from the evidence that we've seen, there are approved providers that do interact with external parties. There are approved providers that don't. There are approved providers that do undertake non-aged care activities, and there are others that don't. So where there's variance, we've depicted it using dotted lines on this graph that you're seeing. And we just wanted to highlight in colors because we're going to reference some of the transparency that we lose in each of those colored areas in a second. The other thing to note as well is there are two areas of those or two primary sources of how those external entities are interacted with by the approved provider. The first one is they can outsource the service delivery to other entities, and they can be either non-related entities, so service companies and subcontractors, or they can be related entities as well that you can outsource services to. The second area that you can interact with external parties as an approved provider is you can actually transfer the refundable accommodation deposit to another entity. And obviously there are guidelines around that, and you'd have to do it in accordance with the guidelines. But essentially you can transfer that refundable accommodation deposit to those entities as well.
And just to stop you there, there's no requirement you observe at a point in your report to obtain security in return for doing so. You don't, the loan doesn't have to be a secured loan.
No, the definition in the Act is that it has to be a commercial arrangement, nothing more.
Thank you.
From what we've seen in the data we've been provided, there was no evidence that there was any security requirement, essentially. So if I can just request to go to the next slide. The diagram is still the same diagram. What it does do is it just highlights areas where we found that there was significant transparency lacking, and that made it difficult for us to essentially assess the profitability and the viability of the sector in a complete sense. And if I may, I'll just like to talk through some of these transparency areas. The detail of this is in section 8 of our report, if anyone wants to read it in more detail. So I'll cover off with the related entities first. Where we lose transparency once money does leave an approved provider to a related entity is we don't have any transparency over the returns or losses that related entity makes from those funds. So we lose visibility of that. We also lose visibility on the extent to which those related entities may actually be supporting the approved provider or vice versa. In terms of the operations of that approved provider. This may include the approved provider's ability to continue as a going concern. And then the third one is we don't actually have a sense, sorry, if I could go back one slide. The third area that we're lacking transparency on related entities is the profitability and the viability of those related entities. So we don't know if there's any insolvency risk or if there's any in the extent where there's related party loans, we don't know any information on the recoverability of those related party loans because we lack transparency on the profitability and viability of those entities that the money is lent to. And then the final one is we have very little visibility on the terms of the transactions with those parties as well. So those are 4 core areas where there's transparency lacking. Similarly, on the non-aged care activities, which are done within the approved provider entity in this example, again, we actually do not have a sense of how much of the returns or losses are made from those non-aged care activities as opposed to the aged care related activities of the approved provider. And we also don't know the risks associated with those activities onto the approved provider. And given our scope was to assess the viability of an organisation, that is also an important factor to consider.
And can there be, Mr. Conductor, can there be, in effect, a cumulative effect of those 2 complexities so that you might have a related party transaction and it might or might not be within the operating segment of aged care that the relevant money's been utilised?
It can, but I would probably point to the guidelines that may prevent an approved provider to be doing that. So they may be on breach of certain guidelines. The detail of that probably wasn't within the scope of our report, but yes, it can. But I think there may be protections to prevent that.
Thank you.
And the other thing I'll just note before I allow any request any questions on this particular page is it's quite important to note that while the structure is complex, it's perfectly reasonable to have that. It's perfectly reasonable for entities to use group structures to maximize returns and optimize their finances and minimize risks. That's pretty standard across multiple industries. So there's no issue with that. Our issue was that we lose transparency over it. So we couldn't actually get a full, complete sense of the picture of the value generated by the industry and by the sector. So when we then report on profitability and viability, what we end up only reporting on is that blue rectangle in the middle of the slide that you're looking at, which is only the approved provider entity. We lose visibility of any returns that may be made in that yellow box on the right, off the back of any funding that may have come from the blue box. So hopefully that makes sense.
Yes, thank you.
Any questions before we move on to the
well, yes, indeed. In the recommendations at the back of your first report, and it is first in time, there's this is on page 0117 and 8 for future reference. But on 117, you've said a possible issue with this relatively complex model is that it arguably weakens the link between the drivers of return and the quality of aged care service provided by the provider. Are you able to elaborate on that, Mr. Fielding or Mr. Kondaka?
The moment it goes to the related entity, the related entity has no obligations to provide aged care related quality of care, and what an approved provider may need to. An approved provider by reputation alone would have to provide aged care services of a certain quality in a competitive market. Whereas once it goes to a related entity, the related entity may be doing non-aged care related activities or various other activities, and their objective may be different. Similarly, as we said in our note on the bottom right of the slide that's in front of you, the objective of allowing this complexity is to allow entities to maximize their returns and minimize their risk using a whole range of strategies. And they may not necessarily have quality of care links to those strategies as well. But overarching though, the guidelines would protect that in terms of the guidelines on what the obligations are of an approved provider.
Guidelines are one thing, but are you saying that the data provided to you originating from annual aged care financial reports given to the Department of Health was insufficient for you to be able to trace and understand the utilisation of those funds by any related parties?
Definitely. That is a very key finding of our report. Yes.
Yeah. Thank you. Please do go on.
Okay. So with that, I'll probably take you to the next slide. We did have to, at the end of the day, still come up with a measure of profitability and viability. So keeping that in mind, we've reported, I've summarized the approved provider level information here. From an income and expense perspective, in FY18, was 25 billion revenue, 23.9 billion expenses, and about $1.1 billion of the profit for the whole industry.
Might just draw Peter to that number there. 23.6% of revenues were from non-aged care activities.
Thank you.
And then similarly on the assets and liabilities side, 73 billion assets, 51 billion liabilities, and a $23 billion equity position. And again, 36.3% of the assets would be estimated to be non-aged care related activities or relate to non-aged care related activities. The detail of that is in section 4 of our report, and we do go through a fair bit of detail on that information. And in our report, we also then...
And Mr. Gonda, just to interrupt you, I'm sorry, and just to repeat, we're just talking about the approved providers and just what's reflected in the reports that they provided to the Department of Health, and it's subject to the qualifications you've made about the adequacy of their reporting.
That's correct.
That so?
Yep. That's correct. We're definitely reporting to simply that blue rectangle in the middle of the previous diagram. That's essentially what we reported on. So section 4 of the report covers this. In section 5 and 6, we actually cover residential aged care and home care in more detail as well, which are subsets of these numbers, essentially. The next point to make in terms of results is profit margins across the providers. There's 2 points I'd like to make on this because profit margins get widely quoted in various different contexts. First and foremost, there's a significant variance across providers in profitability and profit margins. There's a significant variance also between for-profit providers and not-for-profit providers as well. And then the margin itself, which margin do you use to determine when anyone's talking about profit margins? There's net profit after tax, and there is another widely used one is earnings before interest, depreciation, and amortization and tax as well. In our report, we've actually set out a table of the commonly used margins across the board. But what I'll point to as an example of what you can see on the screen, the for-profit providers, if you look at net profit after tax, the bottom 25% of them are still, the 25th percentile, which is Q1, is still a loss-making entity. whereas at the EBITDA level, they're profitable. So so even the 25th percentile of a for-profit aged care provider after tax is making a loss. Whereas on the 75th percentile, so the top 25% are making a profit margin greater than 9.4% as well. So the for-profit sector ends up as a whole making 5.5%. The industry as a whole makes 4.4%, which matches the top left number that we had earlier on an after-tax basis. For our report, though, in terms of assessing profitability and viability, we did use the earnings before interest, tax, depreciation, and amortization measure rather than the net profit after tax measure. We've outlined the reasons for doing so in our report. However, one reason is also that it is the industry used one in the industry. The ACFI report also refers, the ACFA or ACFI, apologies. ACFA. The ACFA report or industry report also uses EBITDA as the margin. So we've referred to that for our profitability assessment. However, we've built the capability to assess it on any method. I won't go through the details of those profitability results and the viability results. You can see them right there. But that's essentially the conclusion that we ended up with.
Thank you. I've just got a few additional questions in the time we have left on a sprinkling of topics. And you've covered the data and reporting topic very well, and thank you for that. And of course, we can read the report and make recommendations or submissions to our Royal Commissioners on the face of the document. However, can I just ask you this with reference to page 0091? I beg your pardon, that's wrong. 0094, I should say. This is half of a table 5.1 entitled Residential Aged Care Income, Expenses and Profit. And I see on page 0094, there are line items for care labour contract, although there are no entries for that one, care labour other, there are some entries there. Is it the case that aged care financial reporting just recently has started capturing this care labour item? Am I reading the report correctly in that respect?
That's correct. Yep. We have gone through the 10 years worth of data, and in the previous years, that may or may not have existed in certain years. And also to note that there may be labour costs in other line items as well, not necessarily the care labour costs that you see. The labour costs that you see there may not be the total labour costs as well.
Because a lot of the accounts have got management fees, so as opposed to having an itemised chart of accounts there would simply be one entry for a management fee.
All right.
Which would do that labour cost.
This is not captured at a facility level, though. Am I reading the report correctly? This is at a provider level.
None of the report
or a geographic basis.
Not even a geographic basis, simply provider basis. Yep. Now, you say a lot, this is at pages 072, 35 and 81 about the complications raised by the structures and related party transactions, but you've addressed it. I won't ask you anything more about that. You do say something interesting at the foot of 0058. You say the operating model, and you've already referred to the operating model and its potential complexities because of structures. The operating model and reporting and acquittal have an important influence on outcomes. And I'll just read it so that it's, I'm paraphrasing it correctly or giving you the quote correctly. The operating model, how the organisations run themselves, has two key features which are likely to be significant drivers of provider behaviour: governance around the ownership of property assets and reporting and acquittal obligations. Now, I'd like you to just expand on that if you can. And we are proposing to the commissioners an acquittal regime for care costs. So you can see the relevance of why I'm asking you this. I'm not asking you to comment on the propositions. We've retained you to give this report, and I'm not asking you to opine on the propositions. But are you saying something there about acquittal obligations and its potential incentive properties when it comes to provider behaviour, and what exactly are you saying?
In this context, it'll probably relate more to the acquittal, visibility of acquittals once it involves related parties or a separate entity outside of the approved provider itself. So the acquittal obligations remain with the approved provider. The keeping that visibility once it leaves the approved provider, any money that leaves the approved provider, that obligation, this operating model, the way it's structured currently, may impact those acquittal obligations. That's what we're saying.
So are you saying that there's a potential effect on behaviour of knowledge that something does or does not have to be disclosed, does or does not have to be reported upon to the Department of Health?
No, I don't think so. I mean, there are commercial reasons why the operating model or organisation structure themselves in a more complex manner. So there's certainly commercial reasons. I can't suggest that they've been done to avoid the acquittal obligations.
There aren't any acquittal obligations in residential care, so I was just wondering what acquittal obligations you might have in mind there. It doesn't have to be proof of particular expenditures, does it?
Well, it would be we would be certainly thinking of expenditure in labour and expenditure on hotel costs, etc. Is the area that we would like to see more granular data, because at the moment, as you've seen, you can't drill down into those expense items to try to determine an appropriate KPI in respect of bed night costs, etc. So that's the area that we would like to see more granular data.
Thank you, I understand. And now on refundable accommodation deposits, you do say a bit about how they introduce complexity, especially when they're able to be, when proceeds of refundable accommodation deposit balances are in effect shared with related parties in various ways. Now, are you able to comment on, sorry, I should just note for the record, you've really gone into a lot of detail on page 0083 in box 1 about the impact of RADs on measuring an approved provider's true return, as you put it. And is the essence of the point there that the ability to transfer the proceeds of RADs from the approved provider that has the liability to repay that RAD in due course to related parties, but without transparency about the terms on which that loan is made, that really introduces significant complexity in trying to understand the returns being made from the aged care business or operating segment?
Yeah, probably less complexity, more opaqueness. So lack of transparency is the issue. So it's not as complex. I think we've made the effort to try explain the complexity. Complexity in itself is not an issue. It's the transparency that's the issue.
A simple example is if the RADs are given to an associated entity to construct an aged care facility, and then the approved provider pays rent for that facility, we've got no information there that can provide us with any insight as to what the cost of those funds are, as opposed to the rental charge that's being charged by the associated entity. So that's a very simple example of the lack of information that we've got.
And could this impact on your estimation of the returns of the sector and the various segments of the sector as set out in your report? Could the returns be healthier, for example? If
we wouldn't know, unfortunately. That's probably the point we've tried really hard to make in our report, that without seeing those numbers, we wouldn't know, which also makes and we've advised this caution in our report as well, any policy changes or suggestions without knowing the extent of that impact makes it really difficult to ascertain.
Yes. And you did a bit of an analysis on comparing the metrics of approved providers which were reporting related party transactions of various kinds with those that were not. And you did an exercise where you removed outliers that were a certain distance above the 75th percentile. And what did you find? This is at pages 25 and onwards, native pages, paginated pages 0073 and following. At the foot of 0073, there are some bullet points. Maybe the operator could bring that up. For this illustrative analysis, we use both the 75th percentile as well as the upper inner fence, defined as the 75th percentile plus 1.5 times the interquartile range, the range between the 75th and 25th percentiles. So you've extended out the boundary beyond the 75th percentile, and you've defined values above that bound as outliers, and you've removed them from the analysis. Is that right? And then you've compared on a with and without basis. And what have you found?
We found that there would be significant changes to the profitability reported, but it's important to note that any analysis where you take outliers out would result something similar, like that's expected. The extent is the question. We weren't sure, we weren't in a position to comment on whether the extent is appropriate or inappropriate in terms of the significance of the size, without that transparency that we were referring to, because we don't have that side of the equation in terms of what are those management fees being used for, because of that lack of transparency that we've been referring to. While these numbers may seem large or as a proportion of the total profitability of the sector, keep in mind the total profitability was 1.1 billion. So if you're looking at management fees reducing by 161 million in the example that we did, that's about 10% of the overarching profit of the net profit tax of the sector. So it is a significant number. I think the point that we'd like to make is we did this analysis just to highlight that further investigation needs to be done into those numbers with transparency, as opposed to coming to any conclusions from those numbers themselves.
So is it fair to say this, that the indications from this exercise open the door to and are consistent with a hypothesis that there are non-arm's length fees being charged in related party transactions around management fees, rent and interest, but it certainly doesn't prove that. It just opens the door to an inquiry.
I think there's enough there to support a hypothesis to look at it in more detail, as opposed to come to any conclusions from the information.
It's come to any conclusion.
Yes, incomplete information, but there's sufficient. The first level analysis, which is why we put it in the report, indicates that the numbers are significant enough that it's worth the expense to investigate further.
Thank you. Yep. I'll just check my notes. We've probably run out of time, but perhaps we'll just ask you a quick question about the frontier economics analysis of the returns. So you've obviously given us your estimates of sector returns and segment returns, and thank you very much. Frontier has taken a somewhat different approach. They've imputed interest to RAD balances, and then they've done a double entry accounting entry, in effect, also treating that interest as a payment by the depositor of the RAD, in effect for rent. And they've drawn conclusions about economic returns as a result. And they've used the expression adjusted EBITDA, and they've calculated returns based on adjusted EBITDA, adjusted in that manner, over assets employed, essentially. Now, what are your views on that methodology? Is that a reasonable approach? Have you taken a different approach, but these are reasonable perspectives on different types of analyses of returns?
I think the context of the two reports may be slightly different. We can't really comment on their methodology. Frontier has
they've used a different calculation.
However, we can say that our report essentially used accounting standards, accepted accounting ratios for margins and things like that. So we didn't adjust EBIT, for example, because the EBIT margin in any standard accounting norm is EBIT divided by total revenue. What we did do, though, having seen the Frontier report on Friday, we just went to reconcile our figures to theirs and just to see that whether the numbers and the results are as expected. And we've kind of summarized it to 3 or 4 things. Firstly, we've obviously used different measures. Their numerator and denominator was different to ours. They've adjusted the figures for the reasons that you've stipulated. We have pretty much the same starting figures. If unadjusted, we get the same ratios. And the impact of the adjustments were in the direction we expected. So they've increased the numerator quite significantly, and they've decreased the denominator. So we do expect their measure of return to be a lot higher than the one we've used, but we would refer you to their report and their justification for why they've used that method. Unfortunately, it wasn't something we could give expert comment on.
Thank you.
Also point out, though, that their report would be subject to the same deficiencies in the data that ours was. So when we talk about capturing income, they relied on the same information that we had. So they'd have the same issues.
Yes, indeed. Thank you. And Mr. Kondaka, thank you. You reminded me that they'd used adjusted EBIT, not adjusted EBITDA as the numerator. I just want to correct that on the record. Look, just finally, you've done a viability analysis, which involves, amongst other things, in one of the early stages of the methodology, which you've explained in the report, an assessment of liquidity. And it's important, you pointed out, to come up with a method of allocating RADs to either current liabilities or non-current liabilities for the purposes of employing that step in the viability analysis. And you've got a table in the report. We don't have time to go to it now, but you've essentially adopted as your starting point an attribution of 80% of the RAD balance of any particular provider to non-current assets. And on that basis, you've come out with a certain figure, which happens to be 10% at the end of the day of providers being not viable on the metrics you've determined. And the figures are even worse if you have greater proportions of the RAD balances treated as current liabilities. Now, why the 80%? How reliable do you think the 80% is? Could it have been more than 80% attributed to non-current liabilities, therefore, in effect, reducing the number of providers who come out not viable?
Sure. I can definitely answer that. The first thing to note there is the reason RADs are put as classified as current liabilities under the accounting standards is because they are technically available on call. What the accounting standards unfortunately does not allow is the benefit of what actually happens, as opposed to the theoretical concept of all RADs are on call at any given time. Historical data has shown that approximately 40% of residents exit approved providers or exit the HK industry. So they pass away or move from approved providers. And as a result, 40% is essentially what's payable in any given year in the last 3 years. And we looked at the data for the last 3 years, and that 40% number sort of is reasonable. Approved providers have to report that as well. So they actually do stipulate it's around 40%. What we then did is we actually also then went, sorry, I've just got a note saying that is an approved provider estimate, that 40% is what they pay out on RADs on any given year. We then gave them the assumption that if someone were to leave, you wouldn't have a vacant room for 12 months. So we essentially assumed the midpoint, giving you 6 months to replace that person. So which is why we ended up saying 20% is what you actually pay out. So we classified 20 as current liabilities and 80 as non-current liabilities. But just to cover ourselves, we did run the scenarios where 40% was included, and I think we did one with 60% in the report, if I can recall from memory as well.
Thank you. I have no further questions.
Thank you, Mr. Gray. Commissioner Briggs. Gentlemen, thank you for your assistance this afternoon. and I need formally to excuse you from further attendance. Thank you very much.
Thank you.
Thank you.
I think we'll adjourn now to 10 o'clock in the morning.
10 o'clock tomorrow. Thank you.
Thank you.
The Royal Commission is adjourned until 10 a.m. on Tuesday, the 15th of September.